Good morning, everybody. We just thank you so much for coming through. We're just gonna give everybody a few minutes to arrive and come in to the session this morning. Good morning to everybody, wherever you are. Thank you so much for taking your time to come through and be with us this morning. And I hope everybody's doing all right. The weather's okay wherever you are. We'd love, of course, to hear from you. We'd love to ask you a few questions and have you just answer a few questions so we can get a bit of an idea of where you are in South Africa and which city that you represent. So we'd love to hear where you are from. There's a few questions that we'd love to ask you. All you have to do is click on the sidebar to the right to answer the questions. Yeah, we'd love to hear your relationship with diabetes. We want to hear what is your relationship with diabetes? Do you have it yourself? Are you supporting a spouse or a partner with diabetes? Do you have a family member that has diabetes? Do you have colleagues that have diabetes? So we'd love to hear your answer to the questions that we're going to pose. But for now, just let us know where you're from. Which city are you from? Pick a city in South Africa that you are from. Are you in Joburg? Are you are you in Limpopo? Are you in Mpumalanga? Wherever it is that you're from, we'd love to hear where everybody is from, so that we get a bit of an idea of who we're talking to. And the majority of the people are logging in from which part of South Africa. I know that in Gauteng right now, it's a bit of a chilly weather. It's kind of cold outside, a bit of rain here and there. So yeah, please stay warm and stay with us. Yeah, we're just gonna give a few minutes to the rest of the attendees to come through, and we're gonna be starting in a little while. Thank you so much for taking your time to come through and be with us this morning. Thank you so much. My name is TT Pasha, and I am your MC for the event today. It's going to be so much information, so much that's going to be happening. We'd love you to be interacting with us throughout this whole time as the different people come through to speak. But just also type in, let us know where in South Africa are you from? Which city are you from? Are you in Jozi? Are you in Cape Town? Are you in Bloem? Maybe there's a new city that we don't know about. We don't know. Are you in Pretoria? Let us know where exactly are you in South Africa so we can have a bit of an idea of the majority of the people where we're logging in from this morning. It's going to be such a great discussion this morning. We have so many speakers that are coming through, so many people that are going to be sharing with us their challenges. They're going to be giving us solutions as well. So there's a lot that we're going to be sharing. Also, let us know, what's your relationship with diabetes? What's your relationship with diabetes? Do you have it yourself? Is your partner or your spouse having it, or a family member, perhaps a friend? Are you supporting a friend? Maybe your work colleague, somebody that you know, that you're close to. What's your relationship with diabetes? We'd like to know that as well. So please answer the questions. All you have to do is click on the sidebar on the right in order for you to answer those questions. Yeah, so if you see the sidebar on the right side, the questions are there. Just click on it and let us know what your relationship with diabetes is, and also which part of South Africa that you're from. So many people that are coming through this morning. So yeah, I think we're gonna start. Runabout now with everything. All right, let's get it cracking. Let's get it started. Good morning, everybody. Good morning. Thank you so much for coming. Thank you so much for logging in this morning. Hey, this is so wonderful. Welcome to South Africa's inaugural Diabetes Summit. Welcome to it. We're so excited to be here with you today, throughout this morning, to speak about the challenges that we have, speak about, talking about the challenges, the things that we face as diabetes in South Africa, and of course, potential solutions to chat like a way forward. What are we going to do going forward? And, also, we'd like to welcome everybody that's here. Welcome everybody in South Africa. Welcome to the speakers, our honored guests, our distinguished speakers, the people living with diabetes, healthcare providers. We appreciate you as well. Thank you to everybody that's here, and everybody who's supporting people that are here as well. My name is TT Pasha. I am a comedian. I'm a radio personality. I'm an MC for today. I'm also, I could have been a doctor, but Matt was like, doctor? So basically, I'm an entertainer. Yeah, I'm an entertainer, and I'm also a diabetic. I'm a type 1 diabetic. I've been living with it for about 12 years. So I understand some of the challenges and things that are going through, and what everybody's going through, because I'm also a diabetic and I'm going through the very same thing. So yeah, as you know, organizing events such as the Diabetes Summit, there's a lot of moving parts that are behind. There's a lot of people that are doing things behind the scenes. It might look like it's me that's doing all of this, but I'm not. I learned how to type on a typewriter, so I'm not typing all these little things that you see. There's a whole team. There's a whole, all the members of the Diabetes Alliance have helped us put this together. We'd like to thank them. Also, the volunteers who've been working on the 5 work streams for SA's first diabetes charter. We'd like to thank them as well. Thank you so much. Thank you also to you for being here, for making this whole thing happen. We'd like to thank you so much for everybody that's been putting this whole thing together. We want to thank our special thank you to the sponsors, particularly our gold sponsors, Abbott, Merck, and Sanofi, for helping us put this Diabetes Summit together and making sure that everything comes together, all the technology and everything that's beautiful that's happening. So thank you so much to our gold sponsors. All right, so real quick, before we get started, I'm going to run you through our virtual meeting platform. Here's how the interaction is going to work this morning. It's pretty simple. Please feel free, okay, to use the chat box that's on the right side of your screen at anytime during the day, so that you can participate, so that you are part of what's happening over. Tell us where you're from, tell us how you relate to diabetes, and you can also comment on the different speakers, as they come through and they give their addresses. Next to the chat box, there's a question tab where you can pose any question for the panelists. So as the panelists speak, you can pose any question that you have for them. These will be moderated and asked directly in the 10-minute question section that we have set up that's after the panel speaks. Don't be shy to ask any questions that you might have, any questions that you need. And as they speak and you want to ask something, don't be shy to pose those questions. Yeah, we want us to have an interactive discussion. We want this to be robust between, and not just a monologue between the speaker just speaking into a camera, but we want it to be interactive, as interactive as possible. So yeah, be free to ask any questions. We're also going to be asking you a few questions as we go along. So please feel free to click on the answer box on the side to answer those questions. And finally, some legalities. The Diabetes Alliance competition law policy is to comply with the Competition Act and all applicable laws in letter and spirit. The full policy statement can be found on our website and can be provided on request. The anti-competitive practices. These are the anti-competitive practices. The Diabetes Alliance does not tolerate anti-competitive practices. Members must therefore not exchange any form of information or enter into agreements or understandings regarding their business activities, such as prices, pricing, strategies, and plans. The Diabetes Alliance encourages anyone who who has information concerning allegation of a breach of a prohibited practice to the Competition Commission. The complaint form is linked from www.diabetesalliance.org.za. Right, now that we don't got that out the way, without further ado, it's time for us to get started. The questions are there as we asked a little bit earlier. What kind of diabetes do you have? Are you a type 1 diabetic? Are you a type 2 diabetic? Or you don't have diabetes at all? Let us know. And also, we'd love to hear from you. What are your expectations for this diabetes summit? What are you expecting to get from the diabetes summit? Let us know. So now it's time for us to introduce our first speaker. Please feel free to answer those questions. What type of diabetes do you have? Also, what are your expectations for this diabetes summit? What are you expecting to get from this whole diabetes? Because at the end of the session, we'll look back and say, okay, these are the things that you feel like have been delivered, your expectations have been delivered, and so on and so forth. Right now, it's time for us to get to the first speaker. I hope that everybody is ready and excited, and you are well prepared to interact with our first speaker. Right. The first person we're going to be calling up is Professor Dawane Kupe. Professor Dawane Kupe was appointed Vice Chancellor and Principal of the University of Pretoria in January 2019. And of course, Professor Kupe holds a BA Honours degree and a Master's in English from the University of Zimbabwe, as well as a DPhil in Media Studies from the University of Oslo, that's in Norway. In December 2019, he was awarded an honorary doctorate degree in humanities from Michigan State University. He has a notable publication record, having authored journal articles, books, and book chapters. Ladies and gentlemen, please let's welcome Professor Dawane Kupe.
Ladies and gentlemen, good morning and welcome to the inaugural South African Diabetes Summit. I'm very pleased to be here today together with so many experts in diabetes and people living with diabetes. We are also joined today by Dr. Kenneth Jacobs, the chairperson of the Portfolio Committee on Health of the National Assembly of the South African Parliament, and many other esteemed guests to whom we extend a warm welcome and observe all protocols. The Diabetes Summit is an initiative of the Diabetes Alliance, co-hosted by the University of Pretoria Diabetes Research Center. The objective of this Diabetes Summit is to start a discussion about the best ways to solve the most obvious challenges when it comes to diabetes in South Africa, and to point towards development of an effective diabetes response. In doing so, we can look to address one of the most urgent health crises facing South Africa today. Diabetes accounted for 5.5 of deaths in South Africa in 2017 and was the leading cause of death among women, according to Statistics South Africa. We know that South Africa also faces an extremely high obesity rate, with 68% of women and 31% of men overweight or obese. These high rates of obesity contribute to the high prevalence of diabetes. Diabetes clusters with other chronic inflammatory diseases and conditions as part of the metabolic syndrome. The direct medical cost of type 2 diabetes, which accounts for 90% of diabetes cases in South Africa and worldwide, is also significant. In 2018, public sector costs of diagnosed people with type 2 diabetes were approximately 2.7 billion rand and 2.8 billion if both diagnosed and undiagnosed people with diabetes are considered. In real terms, the 2030 cost of all type 2 diabetes cases is estimated to be 35.1 billion rand. 51% of these 2030 estimated costs are attributable to the management of type 2 diabetes and 49% to complications. In addition to this, we know that people with diabetes are among the hardest hit during the ongoing COVID-19 pandemic. Addressing diabetes in South Africa needs to be approached as a matter of urgency. The University of Pretoria recognizes this need, which is why we launched South Africa's first exclusive diabetes research center at a public academic institution. Although housed in the Faculty of Health Sciences, the center adopts a transdisciplinary approach and works across faculties to develop research that aims to improve the lives of people living with diabetes. As you may be aware, the University of Pretoria is a future-focused institution and produces research that makes a difference in society, nationally, across our continent, and makes a contribution to this, to many such issues globally. We're at a point in history where we can turn the tide on diabetes. We can flatten the curve if we all work together, and if we make diabetes a national priority. This morning, we'll be looking exactly how to do that and why now is the time to act. I thank you.
Thank you so much, Professor. We appreciate that, and we thank you for opening in such a great way. It's such an honor to be with guys like you this morning, and every speaker that's going to be coming through this morning, sharing their expertise. We thank you so much for taking your time to be with us today. We know that you're very busy. Yeah, but right about now we're gonna move on to our next speaker, and do Professor Naomi Levitt was supposed to be with us right about now, but she's having a bit of challenges here and there with connecting. So we're gonna move on to Dr. Kibachio Mwangi. Dr. Kibachio Mwangi is currently the medical advisor for non-communicable diseases and mental health in the World Health Organization, South African country office that's in South Africa in Pretoria. Right about now, there's there he supports the Ministry of Health on public health policy, as well as NDCs and their determinants at the national and provincial level. Without wasting more time, let's get to Dr. Kibachio Mwangi. Doctor?
Thank you, Tishi. Thumbs up if you can hear me. Thank you. It's awesome to join you guys, and thank you, Titi. We hear your voice and we see you. You're doing a great job. Let me start by thanking you for your lived voice. You know, when you started, you said, hey, I wanted to be a doctor, but math wouldn't let me. I'm living with diabetes. Your voice is much more important than even mine. You speak a lived experience of diabetes. I only read diabetes in books, so please don't underestimate your voice. When you speak volumes because you have lived these, the challenges of diabetes, of access, of lack of awareness, of stigma. You live them day to day, and so when you speak with more authority than me, who is a medical doctor. Having said that, allow me to welcome all our esteemed speakers. Thank you, Prof, for opening this on a very high note, and we appreciate the work that the University of Pretoria is doing. And I'm happy that as WHO we are part of the Diabetes Center that you're putting up as a think tank and as a research hub that will be able to move the needle on research, and I'll be speaking about it in a while. It's good to see many people. We are approaching 200, and this is quite a testament of the interest that we are putting on issues diabetes. We may be living with diabetes, we may be carers of a person with diabetes, we may be friends of a diabetes cause, we may be just citizens who are worried or are interested in this space. And I must thank Bridget and team of volunteers and the Diabetes Alliance for taking the challenge. I remember a few months ago, I think 1 or 2, we talked and we agreed, hey, why don't we do this? And I'm happy that you took the challenge and heeded the call. And I have looked at the charter that you have come up with, and I can only look forward, as this is, I would say, the commencement of great partnerships, and also is a setting up of strategic partnerships that would support the Department of Health in developing things like an operational policy, strategy, or action plan for diabetes. With over 420 million globally living with diabetes, and the fact that 1 in 2 adults with diabetes don't even know that they have, and hearing back home, close to 4.6 million people living with diabetes, I think it's time to redouble our efforts. It's time to look at our policy coherence to see where is this policy inertia coming in. I know that our focus today is diabetes, but it is impossible not to mention a little on obesity and hypertension and the current COVID-19, with which it has interacted with the NCDs in a syndemic. We epidemiologists look at pandemics, and when 2 pandemics are working in a synergistic manner, like the NCDs and the COVID-19, we call them syndemics. And this syndemic has taught us a lot, and we would be unfair not to learn from these lessons and build back better. The clarion call is getting louder and louder, and something has to be done for diabetes. And I'm happy the Diabetes Summit in South Africa and has come up following the alliance, saying, hey, we need to do something. The cost of inaction far outweighs the cost of action, and I'm happy that we are taking some action. So I was told to talk about the WHS 74.4, but just before then, let me just take you through an advocacy journey that we have taken in the last decade on issues NCDs, and especially for diabetes. From late as I think 2011, when we had the first ministerial conference in Moscow, there was a declaration towards commitment to a pathway of heightened policy attention to NCDs. Then we had the first United Nations high-level meeting on NCDs that had a president, and the primary role here and responsibility of government was highlighted in terms of responding to the challenges of non-communicable diseases. We were asked to develop adequate national multi-sectoral responses and to prevent and to control NCDs. We then later at WHA 66, we had endorsed in 2013 the Global Action Plan for NCDs, where diabetes was a key component. Diabetes acts as a barometer of the other NCDs. If diabetes policy is going south, definitely the NCD policy is not doing very well. So we usually look at diabetes as a barometer of what the other NCDs and mental health is happening. Then we had the second United Nations high-level meeting that was a point of concern. There was a lamenting of the lack of progress and commitments that we had made in the first United Nations high-level meeting. And then in the post-2015 developmental phase, where we came up with the SDGs and the SDG 3.4 that highlights issues, NCDs, and mostly, again, diabetes mentioned here. We have had not 1, not 2, but 3 high-level meetings on NCDs. It's actually the disease that has had the most United Nations high-level meetings. And when an agenda moves from Geneva to New York, then we expect policy attention to be heightened, but also response in terms of resources and financing to come with it. But the question is, why not? So we had the Diabetes Compact that was launched during the centennial celebrations early this year, when we were celebrating 100 years of access to insulin. Insulin was discovered 100 years, and so we were celebrating this. So at the time when we are looking at the World Health Assembly 74.4, the resolution, this resolution is looking at reducing the burden of non-communicable diseases through strengthening prevention and control of diabetes. And it has many, many provisions, but I will not talk about many because of the 5 minutes that I was given. So it looks at strengthening national capacity, and we must rally around the government and the Department of Health to help them to strengthen leadership, governance, and most importantly, multi-sectoral action and partnerships. Remember, diabetes is not purely a health issue. The causation of diabetes, much of it lies without or outside the purview of the health sector. It's about how we do agriculture. It's about how we do our marketing. It's about how we do sports. It's about security. It's about marketing. It's about everything else except health. Health only comes in to treat. And so we cannot ignore the other sectors and, assume that we're doing much about diabetes. So we must involve the other sectors and also the non-state actors, especially the private sector, and also people living with NCDs that are a core part of the response. I use the words of Dr. Vicky from the NCD Alliance, who said, there is nothing about us without us. So the people with diabetes must be in the core of driving this agenda. The resolution also asks to strengthen and orient health systems to address prevention and control through people-centered primary care and universal health coverage. This is an important agenda, and I ask Bridget and team from the Diabetes Alliance, please do not be left behind. Go to every of these meetings. You know, they say you are either around the table or on the menu. So please make your voice heard. It's a civic duty. Represent the people with diabetes, and every one of us here. So please, we also want to support the the Department of Health through participation, and also lending our voice in the spheres of influence that we have. Titi, you are a radio personality. You have a beautiful platform to speak about diabetes every time. And it behoves us to, first of all, understand, and also so that when we speak, we're able to, first of all, educate people, let them unlearn the things that are wrong about diabetes, and also to demystify myths and misconceptions about diabetes. And finally, this resolution also wanted to promote and support capacity for high quality research, and also not only research, but also translation into policy. I'm happy that Professor Tawana and Patrick are on the forum, and with the University of Pretoria, we're working to see how can we support this beyond just research, but research and translating it into policy. We also need to support surveillance and monitoring. Following this resolution, we committed ourselves to the 80, 60, and 100 target. As you may know, we are borrowing heavily from the HIV 90-90-90 targets. And we were looking at 80% of the people diagnosed with diabetes that are diagnosed. So we are going upstream to make sure that people who are screened and those who have diabetes are known, 80% of them. And this is a good control of blood pressure. 60% of the people with diabetes receive statins. And of course, 100% of the people with type 1 diabetes, like you, Titi, have access to insulin. And it's not just access in terms of the stores. Insulin in the stores is not useful. Insulin under the skin and controlling glucose and preventing long-term complications is what is useful. Now, with all these activities and with all this that I've said, why the policy inertia? Why don't we see action? So how can we move the agenda beyond and increase commitment, action beyond commitment? And I'm happy such a forum is able to come up with solutions that we can work with government and not only push government, but also work as partners with government to make sure that we move. As I conclude, let me draw on the Global Diabetes Compact also, which was an action to try and look at how do we reduce the risk of diabetes and ensure that people who are diagnosed with diabetes also have access to equitable, comprehensive, affordable, and most importantly, quality treatment for care. This compact was launched along the centennial celebrations of Insulin 100, and it worked towards asking us to collaboratively unite stakeholders, including people living with diabetes, around the common agenda, also to integrate diabetes prevention and management in primary healthcare platforms. The person with diabetes, the person with HIV is the same one, so we need to integrate this so that they have access to health and not a siloed approach towards health. There has to be these silos because of programming and planning, but at the point of access, then everybody should have access. Research, we need to close this gap, and I'm happy that we have formidable partners from the academia here to help us with this. Just remember that South Africa is blessed with a lot of academia, a lot of research goes on, but unless this research is tied together in a comprehensive manner, it may even create some confusion and also disenfranchise the government, not wondering where to start with all these voices. So we need a platform to help them to synthesize for policy and planning. And of course, we need to improve the investment of diabetes and NCDs. The cost of inaction far outweighs the cost of action. I think I'll stop here by calling a building back better agenda that we have started with the Department of Health. We are here to support them, take the lessons from COVID and translate them into policy actions that can improve the livelihoods and the outcomes of people living with diabetes. Over to you, Titi, and thank you.
Thank you so much, Dr. Mwangi. Thank you so much. Making so many great points that you're making over there. But, you know, the thing that you said stands out is that, you know, we can all make a difference, you know, whatever field that we're in, everybody has the power these days in their hands to make a difference, you know, to have a voice. I mean, I am on radio. I speak to a lot of people on a day-to-day basis, and you know, we try to do our best to you know, to let people know about diabetes and give more information as we go along. You know, even on social media, if you have social media, Facebook, Twitter, Instagram, you know, everybody has a voice these days, and we can all make a difference. You made so many great points that we can't go into all of them at the same time. Thank you so much, Dr. Mwangi. Right now, we're going to move on to our next speaker, who is Dr. Yogen Pillay. Dr. Yogen Pillay is the director of the Clinton Health Access Initiative in South Africa since June of 2020. Between 2008 and 2020, he was the Deputy Director General for Health Programs in the National Department of Health. Prior to this appointment as DDG, he held positions of Chief Director of Strategic Planning and Director for the District Health System in all the National Department of Health. He holds a PhD in Public Health from Johns Hopkins University, and he has been a member of the Ministerial Committee on National Health Insurance and continues to lead the national effort to develop service benefits for various levels of care. Ladies and gentlemen, Dr. Yogen Pillay.
Titi, thank you very much, and good morning to everyone, all protocols observed. On the 14th of this month, Sunday, we will be commemorating World Diabetes Day with the theme of access to care. And not surprisingly, this is the theme because 100 years ago, insulin was discovered at the University of Toronto. And I see there are many comments on the chat about availability of insulin and making insulin available to as many people as possible, but also having the strips in order to know what people's glucose levels are. So I'm delighted to be part of the inaugural South African Diabetes Summit and thank the Diabetes Alliances and as well as the University of Pretoria for this invitation. Many speakers will be speaking about diabetes and its diagnosis and treatment at the individual level. I will speak about it from a public health perspective. And I'll speak about it also not only because of the fact, as Prof. Cooper as well as Dr. Mwangi said, it's part of a set of challenges, conditions that we are currently confronting, not least of which is COVID, as Dr. Mwangi reminded us, but also climate change. And I think given that COP26 is happening this week and will conclude this week, and we hope the negotiations are successful, that there are a number of things that COP26 will deal with and climate change will be responsible for that links to diabetes, including sedentary lifestyles, urbanization, and most importantly, processed foods. So while it is clear that preventing diabetes type 2 in particular requires both an individual as well as a public health approach, I will be focusing purely on the public health approach, as Prof. Rieder, Prof. Levitt, when she comes on, and others will, I'm sure, speak about the diagnosis and treatment of diabetes at the level of the individual. And I see on the post, and I fully agree, that the treatment of diabetes needs a multi-sectoral and an interdisciplinary approach. Prof. Cooper has already spoken about the cost of treating type 2 diabetes. Priceless, which is an institute at Wits University, has been doing a fair amount of work with the Department of Health on the cost of type 2 diabetes. And Prof. Cooper did mention that treating those that are already diagnosed in 2018 cost an estimated 2.7 billion rands. And if we have to treat everyone, including those that are not yet diagnosed, which is about 50% of the population, the estimated costs are closer to 22 billion rands. Now, that's money that the health system currently does not have. So if you don't have the money to treat something, you've got to prevent it. So there are many ways to think about a public approach to diabetes. Bergman and others, who published a paper in 2019, note that the public health approach can advocate for diabetes prevention, especially for high-risk individuals, as well as changes to the environment that makes it easier for people to practice healthier behaviors. Just asking people to practice healthy behaviors is clearly not sufficient. Others, such as White, in a paper published in 2016, argue that changing individual behavior has limited reach, as it is not easy to identify those at highest risk at scale, and that behavior interventions at the individual level have variable levels of effectiveness across subgroups with different demographic characteristics. And this is particularly true of a country like South Africa, where we know, for example, people are from different demographic population, so-called population groups, have different levels of risk for diabetes. The diabetes levels in KZN and Durban, for example, are much higher than anyone else. So this is well described by Siegel and others who published a paper in 21, who note that a person's ability to manage their diabetes is affected by a range of factors, including the burden of treatment, including adherence, poverty, the immediate social context, deficiencies in the health system, and some of that's been already posted in the chat, as well as the financial burden of dietary changes that's expected. So what is needed? What's needed is a life course, whole of society, and intergenerational approach that tackles the multiple drivers of diabetes at the same time. Such a program called War on Diabetes was implemented in Singapore in 2016. They adopted a life course perspective and multi-sectoral and population-based approach to reducing the prevalence of modifiable diabetes risks. For example, overweight, which was referenced already, obesity, referenced already, physical inactivity, and unhealthy diet in the general population. This also meant, for Singapore, addressing the commercial determinants of health involving the multinational and transnational corporations, as their products and marketing of these products have been shown, in some instances, to be detrimental to health. Coincidentally, on the 5th of November this year, the World Health Organization released a fact sheet for the first time on the commercial determinants of health. While the social determinants of health focuses on the circumstances which one is born, live, and work in, the commercial determinants are, and I quote from the WHO document, the conditions, actions, omissions by corporate actors, unquote. These actors, corporations, shape the physical and social environment in which people live, work, and recreate. The same can be said for governments, often by their inaction. If you look at the physical environment that we live in and how safe or unsafe it is to perform physical activities outdoors. And this is particularly true for children, adolescents, and women in South Africa. With respect to diabetes in particular, the products that are sold as well as its marketing, for example, ultra-processed foods, tobacco, sugar-sweetened beverages, and alcohol, all contribute to unhealthy diets. These products and advertising strategies typically target the youth, who are especially vulnerable. And the WHO notes the following, that the fast food advertising used in many countries, including South Africa, targets the youth market, and I quote from this document, activates highly sensitive and still developing pathways in teen brains. That's why an intergenerational approach to diabetes is so important for South Africa. In addition, corporates are known to influence government policy to increase their market share and profitability. Of course, corporates can also do good, so they're not all bad. Some examples that corporates can do are reformulation of food products to, for example, reduce salt and sugar content and increase access to, for example, vegan meal offerings in supermarkets and restaurants, which reduces red meat consumption, which can in turn reduce methane emissions, which is a big issue that's being discussed at COP26, and also save the Amazon from deforestation, because we know that there's a significant amount of deforestation as a result of ranching in Brazil, for example. Apart from Singapore, other examples at country level include more than 50 countries, including South Africa, that charge a tax on sugary drinks, countries like Mexico and Chile that have front of packaging label, an example that hopefully South Africa will follow very soon, and we should really advocate for that with the Department of Health, and the UK, which will ban junk food advertising online and before 9 p.m. on TV from 2023. And finally, 96 countries have adopted some initiatives to reduce salt intake. So there's a lot we can do. There's some things we are doing, but clearly there's more we need to do. A local initiative that I'd like to profile is the Western Cape on Wellness program. At present, it targets wellness at the individual level, even though it is said to be a multi-sectoral program involving schools, workplaces, as well as the health sector. One would like to see this program extend beyond to the structural and environmental issues that I spoke to as well. Perhaps a stronger partnership with the national government with respect to national legislation is required to take the Western Cape on Wellness program to scale. In conclusion, public health measures can prevent type 2 diabetes and should be deployed alongside interventions at the individual level. Governments have and can legislate to ensure that corporations do not or limit production of foods and beverages that are unhealthy and that promote the production and marketing of food and beverages that are healthy. So there are many things that government can do more of. Consumers too can help to shape the market for healthy products. The rapid rise of vegan products in supermarkets and some restaurants has shown that consumer choices do matter, but we cannot leave it to individuals acting in particular ways. We have to have a whole of government, whole of society approach to diabetes prevention. In conclusion, there's clearly much that can be done, but there is so much more that needs to be done, both at the individual level, at the health sector level, and at the societal level. I do hope that this summit, therefore, kicks off a national campaign on diabetes, which has a great sense of urgency. The numbers that we are speaking about, untreated, pre-diabetic, as well as the cost of treating diabetes, is avoidable for the most part. And I would like to thank again the organizers for inviting us to participate, and I wish us much success. I thank you very much for your attention.
Thank you so much. Thank you so much to Dr. Pillay for giving us that presentation and let us know, his expert opinion. So yeah, we're going to move on right now and ask those Mentimeter questions. And now these are the questions that I told you that we're going to be asking throughout this whole experience to find out, how you feel about certain topics. So yeah, don't be shy to type in your answers. Now, the next question that we're asking, also, you need to put in your code. There's a QR code that you need to scan with your phone in order for you to answer those questions. Up next, we're going to be having Professor Naomi Levitt. But before that, let me just put the questions up, the Mentimeter questions. What do you most want to see improved with diabetes care in South Africa? What are your biggest frustrations with diabetes care in South Africa is also the question that you need to answer. What you need to do is scan the QR code right there and get a chance for you to answer those questions that we're going to be putting up. Do you think there's sufficient support for diabetes and mental health? Do you believe that there's sufficient support for diabetes in SA and also for mental health? Another question that we're asking is, do you feel that there's enough emphasis on diabetes awareness and education in South Africa? Do you feel like that is also given time? Awareness and education in South Africa when it comes to diabetes. And also the last question, any ideas on how we should fix that? Because we're all about movement. We're all about, fixing the problems that we find out there. We're not just going to say these are the problems, but we also try to find ways to fix those problems. Right now, we're going to go to Professor Naomi Levitt, who is a diabetologist, okay? Also a public health scientist. She is a senior scholar at the Division of Endocrinology and Diabetes at the University of Cape Town, and the director of the Chronic Disease Initiative for Africa. And she also has been involved in many national and international efforts to address clinical practice, research direction, and policy relating to diabetes. She's a fellow of the University of Cape Town and has authored over 270 peer-reviewed publications and 14 chapters in books and monographs. Ladies and gentlemen, it's our honor to welcome Professor Naomi Levitt.
Good morning, everybody. I'm afraid I can't seem to bring up my presentation. Hello, are you able to hear me?
Yes, we can hear you clearly. We have, I think, Kristen is going to be working on it. Bridget is probably working in the background to help us fix that.
Prof. Levitt, if you'd like to email it to me, I can share it for you.
If I email it to you, turn off my camera. Just hold on a moment.
Sure.
Right. Okay. Well, while they're still getting that fixed, yeah, I think it's also an opportunity for us to get to those Mentimeter questions. Those Mentimeter questions, don't forget, just answer them as honestly as you can. What do you want to see improved with diabetes care in South Africa? What are your biggest frustrations with diabetes care in South Africa? What are those biggest frustrations? What frustrates you more about diabetes care in South Africa? Also, do you think there's sufficient support for diabetes and mental health as well? Do you feel like there's enough emphasis on diabetes awareness and education in South Africa? Is enough being done? Do you feel like there's enough being done when it comes to that? And do you have any ideas on how we can or we should fix that? Those are the questions that we need you to answer, and we'll be getting to that later. I believe Dr. Naomi, Professor Naomi, are you ready?
Yes, I am, and I'm terribly sorry to be late. I'm a victim of load shedding.
Oh no, we are all victims. We are all victims of it.
Yeah. So
take it away.
I'm terribly sorry because I think that my presentation is out of sequence. But what I wanted to do was actually apply a historical perspective of diabetes in South Africa from 1991 to the present, and to indicate where we've been, where we are, and where we need to go. Right, so actually the presentation doesn't move. Okay, so
it wouldn't be an online event if someone didn't have every possible technological difficulty, Prof. Levitt, so you're taking them for us.
My friend Joel is going to help me. My friend and colleague Joel. I mean, so let me start. So in the early 1990s, the prevalence of diabetes was 6% in the urban townships of Cape Town, which was actually quite moderately high for sub-Saharan Africa. And of the people who were seen in our diabetes prevalence study, half of them were not diagnosed. Here we can see half of them were not diagnosed, as you can see on the right-hand side. And 2/3 of the people with known diabetes were attending the health services, which means that 1/3 were not attending the health services. And the question is, why were they not attending the health services? However, if we look at the top right-hand side of the slide, you'll see, well, what were the modifiable risk factors? And even then we identified that obesity was a potentially modifiable risk factor. And the other important and intriguing risk factor was the proportion of life spent in an urban area, which speaks to the issue of urbanization and the multifaceted nature of the stresses, the changes in lifestyle that occur with urbanization. At the time, we audited primary health care for diabetes, and we found that the level of control was poor. You can see what the mean hemoglobin A1C was at the time, 10.5%. It was really high, and few people were within the controlled area. And only just over 1/3 had controlled blood pressure. which speaks to real problems with healthcare delivery. But this was shown even better by the fact that when we examined patients, people with diabetes attending the health services, we identified that at least 3/4 had at least one complication, and of those complications, eye complications were present in just over 60%. Foot complications were present in just over 1/3, and you can see that 1/3 also had renal impairment. And this is incredibly important because we know that if we identify, and of the people with retinopathy, 15% had retinopathy that required evaluation by an ophthalmologist and potential laser therapy, i.e. life-saving, sight-saving interventions. And we know that that amputations were incredibly prevalent at the time and over the past period. And amputations are entirely preventable. The reason for the asterisks there was to show you that all of the complications were undiagnosed, had not been identified and recorded in the folders, with very, very few exceptions for absent foot pulses and persistent proteinuria. Well, that was where we were then. Where are we now? Now, actually, the prevalence of diabetes has risen. The latest data shows that the prevalence is in the region of 15%. That's if we look at all of the populations in South Africa. But it's important to note that half of people with diabetes identified in community surveys are still unaware of the diagnosis. Poor glycemic and blood pressure control is ever present. 20 to 30 people with diabetes achieve glycemic control, and the same for blood pressure control. There's infrequent assessment for complications and measurement of hemoglobin A1C. And in front of you, you can see a graph that goes from 2009 to 2018. The orange block gives you the proportion of people who have had hemoglobin A1C measured in the past year. You see it's 10%. And under 5% of people in the study had had their feet examined or had their eye screened for retinopathy. These are all preventable problems associated. These are preventable complications associated with diabetes. So not only do 50% of people with diabetes in the community not know that they've got the diagnosis, there's poor glycemic and blood pressure control, and there's infrequent assessment for complications of diabetes. I want to highlight an additional factor that has become it's really occupying our minds more and more these days, is this whole entity of diabetes in pregnancy. And what has happened is, as the proportion of women who are obese and overweight has increased, so we are seeing diabetes in pregnancy more and more often. And you can see the prevalence is between 10 and 26%. What is really concerning is that once somebody has had gestational diabetes or has diabetes that is first diagnosed in pregnancy, there is a high rate of progression. In studies done in Cape Town and in Soweto, the proportion of people who progress to diabetes within 5 years is in the region of 40 to 80%, depending on the degree of hypoglycemia in pregnancy. And what is really concerning is that when women are found, are tested at 5 years, the vast majority are undiagnosed. The last concerning number is that diabetes is the #1 cause of death in women and #2 in men. So I think this sketches a really dismal picture of diabetes in South Africa, because in many ways we have not progressed over the last 25 to 30 years. But I'm an eternal optimist, and I believe that with combined engagement, combined activity of stakeholders, Department of Health, people with diabetes, who I hope will form a very active and vocal group demanding changes within government, local, provincial, national, so that diabetes care is improved. I think we will be able to go far if this happens. What can be done? Jürgen Pillay has spoken about prevention. The whole of society approach is pivotally important for diabetes prevention. We need to change the trajectory of diabetes, numbers of people with diabetes. It really needs to be truncated and to diminish over time. And I believe with a whole of society approach, this can happen. The second element consists of screening people for diabetes. Now, I'm not in favor of generalized screening of people for diabetes. I think that we have a captive audience, women who have diabetes in pregnancy. Once they've had their pregnancy, once they've delivered their baby, they go back to the health services and nobody follows them up. If we were able to follow up women who've had diabetes in pregnancy within the first year postpartum, identify those who still have diabetes and get them into the system of improved healthcare, we will not only impact on the woman, we will impact on the babies and on the family. And finally, we need integrated, accessible, quality, person-centered care. And I know this is a mouthful, but diabetes care is not just about the individual who has diabetes. It is about the health system. It is about creating a health system that is welcoming, engaging, and enabling the person with diabetes to have the skills to take care of themselves. We know that if people have improved glycemic and blood pressure control, we will change the trajectory of mortality associated with diabetes. So I think that the life course approach is absolutely critical. I think that pregnancy and post-pregnancy provides a window of opportunity for diabetes prevention in the future. And the current data shows that roughly a third of people over the age of 55 have type 2 diabetes. The majority are undiagnosed. So if screening is limited to people at extremely high risk, I think we will go some way towards addressing this diabetes epidemic in our society. I look forward to hearing the rest of the presentations at this meeting, and I do hope that this meeting, this summit, will lead to fundamental changes in the way we approach diabetes as we all join hands to fight this problem facing our society. Thank you.
Thank you. Thank you so much to Professor Levitt. Thank you for sharing all that information with us and giving us that much info and taking your time to be with us throughout the challenges of technology and ESCOM, of course. But we thank you so much for taking your time to speak to us. Right now, we're going to be going through to some of the videos that we have. So there's video presentations that we have. The whole point of the Diabetes Summit is to improve the lives of people living with diabetes. And of course, we don't want to speak on their behalf. We want to hear directly from the people that are living with diabetes, because the whole point and the whole saying is nothing for us without us. So we want to hear directly from them and their challenges and things. Because I mean, I'm diabetic, as I said a little bit earlier, and I have my own challenges as well. The biggest challenges that I have is just food, maintaining discipline with the right kind of diet. Because today you might eat properly and have a good balanced diet, and tomorrow you feel like, man, let me just celebrate what I ate yesterday by eating a whole leg of a lamb today, and it's setting you back. So we're going to find out from people living with diabetes throughout this whole morning. We'll be hearing from them, finding out what they have to say directly from them, and this is to get us kicked off. Let's check them out.
Hello, my name is Linda. I'm 59 years old and I have been living with type 2 diabetes for the past 16 to 18 odd years. I'm also insulin dependent. I think my biggest issue that has really not changed over the years is the fact that GPs treat the symptoms of type 2 diabetes and not actually the cause. And also more importantly is that they treat our type 2 diabetes pharmaceutically rather than instilling values of a lifestyle change which can actually reverse the condition completely. It's evident that, in my opinion, that a lot of doctors are actually not trained in the lifestyle management of type 2 diabetes, thereby opting purely for the pharmaceutical option, which I think is partly the reason that this disease rather is just consistent and maintained in our lives for so long.
Hi, my name is Michael Marnowick. I'm a type 1 diabetic, type 1.5 or larger to be more exact. Previously diagnosed as type 2, but that was changed about 4 years ago, and for the better. I'm a diabetic who fights hard for my health. I see that as the most important thing, and I believe that long term I want to be healthy and as healthy as possible. So for that reason, I do look after myself. I take great care. I'm probably in the best health of my life at 52. That's not a boast, but I think it's more an attitude. And the big change for me came with this baby, the continuous glucose monitor, that has really changed my controls. It just took me to the next level. And I felt that, it just gives you all the opportunities and the education to be the best diabetic you can be and in the best health of your life. Thank you.
Hi, my name is Tapi Semenya, and I'll be talking about my personal mental health and diabetes experience.
Myself, I take great care. I'm probably in the best health of my life at 52. That's not a boast. Thank you.
Hi, my name is Tapi Semenya, and I'll be talking about my personal mental health and diabetes experience and access to mental health care. So I have been having bipolar disorder for 4 years, and in the 4 years, my medication hasn't been exactly paid for in full by my medical aid. There were times that I needed to pay my medication by using cash or by either going to a public hospital and getting my medication from there. And the biggest limitation in care for mental health is that we still have the stigma around going to therapy due to the fact that therapy is seen for people who are crazy or people who are having mental issues. And that has really scared a lot of people away from going to therapy, even though access to therapy is there. Thank you.
Yes, so that's what it's all about. It's all about hearing the different challenges that they go through in their own voices. People living with diabetes. We're going to have more of those videos as we go throughout this morning. Next up, we have a panel on the current South African diabetes situation that's moderated by Dr. Patrick Ngasa Pioti, the Senior Program Manager at the University of Pretoria Diabetes Research Center. Dr. Pioti is joined by Professor Joel Dave, the head of endocrinology at the University of Cape Town and Groote Schuur Hospital, and Dr. Sandeep Ruda, an endocrinologist and non-executive member of the Society of Endocrinology, Metabolism and Diabetes of South Africa, Professor Paul Ryder, the director of the University of Pretoria Diabetes Research Center, and Buyelwa Majikela Zalangamandla, a clinical educator at the University of Cape Town in the Division of Diabetes Medicine and Endocrinology, and the diabetes coordinator at Groote Schuur Hospital. Also on the panel is Shivani Rankod, who's the CEO at Percept and a long-term government advisor, Daniel Shear, a clinical psychologist living with type 1 diabetes, and Gina Langa, who's living with type 2 diabetes and accessing her healthcare in the state sector. Right now, I'd like to give over to Patrick, Dr. Patrick Ngasa Pioti. Dr. Patrick.
Thank you, Titi. Thank you for having us this morning. We are about to discuss the diabetes response in South Africa. I'm Dr. Patrick Ngasa Pioti from the University of Pretoria Diabetes Research Center. I would like to welcome and to greet all our esteemed guest this morning. As you can see, we've tried to bring together people from different perspectives to have really a 360 view of the situation with diabetes in South Africa. We will start with Prof. Rieder, the director of the University of Pretoria Diabetes Research Center. Good morning, Prof. Rieder. I would like to start with you just to understand what is diabetes and what is the size of the diabetes problem in South Africa. I think we lost Prof. Rieder for a second there. Prof. Dave is here.
Online, can you hear me there?
Yes, Prof, we can hear you.
Yes, okay. Yeah, sorry, Patrick, the gremlins. It was my time for a gremlin. I just lost connectivity there for a minute. Just rephrase your question quickly, Patrick.
We would like to start just to paint the picture. What is diabetes and what is the size of diabetes in South Africa?
Yeah, thanks, Patrick. So I think a number of the previous speakers have already alluded to the huge burden of disease in South Africa. So I think in short, one can say that on average, about 8% of South Africans have diabetes. As the previous speakers have said, this is increased in certain populations. So, for example, the Indian community in Durban and some older studies also indicate that the is probably higher in the Western Cape. Of course, it's also age-related. So the older you are, the more likely you are to have diabetes. But I think we can come African population. That means that we've got about 2 to 3 million people living with diabetes in South Africa. I think the worrying thing is, of course, is that this is going to increase eventually over the next 10 years. So 10 to 20-fold increase by the year 2035. So I think that's what's very worrying. All of this, of course, driven by the obesity epidemic, which was also alluded to before. So the fact that, that 7 out of 10 of South African females and probably 4 out of 10 South African males are either overweight or obese. So that's the scope of the problem. So yes, we have a huge problem in the country. So an increasing, growing problem, literally and figuratively.
Thank you, Prof. So increase 10 times by 2025, having high now about 2 to 3 million. So we can see this is a considerable situation in the country. And the situation was actually highlighted since 2019 with the advent of the COVID-19 pandemic. And we have Prof. Joel Dave all the way from Cape Town, who was very much involved in the COVID response in Cape Town. Prof, can you please share from your research and your experience as a clinician, why has COVID-19 highlighted the crisis with the diabetes epidemic in the past 2 years?
Thank you very much, and thank you very much for inviting me to be part of this wonderful program and alliance and this panel. And I think Professor Rieder has shown that the great problem with diabetes in South Africa. So there's no doubt that these two pandemics of diabetes and COVID were going to collide. And very early on in the pandemic of COVID, we saw from other parts of the world in the north that unfortunately people living with diabetes were at great risk of developing more severe disease. We were hoping and keeping our fingers crossed that the situation might have been a little bit different here in South Africa, because the single biggest predictor of a worse outcome from COVID was age. And we know that our population age pyramid has a very different shape to those countries in the north where they were really having a great mortality, especially in those over 60. Unfortunately, it didn't quite pan out like that. And the South African patients who are living with diabetes, unfortunately, were exposed to more severe disease. In a study that we published from the first wave, we saw that out of 66,000 people diagnosed with COVID-19, only 9,305 were people living with diabetes, which was a prevalence of about 14%. And that was sort of similar to the background prevalence of diabetes in our setting, showing then that it didn't look like people living with diabetes were at greater risk of being infected with the SARS-CoV-2. However, when you had a look at those needing admission at least 45% of people living with diabetes needed admission. And of all those who died from COVID, 50% were people living with diabetes. So there's no doubt then that once a person living with diabetes got COVID, they were unfortunately had much more severe disease, were more likely to require admission, were more likely to require oxygen and admission to the ICU, and unfortunately were more likely to die from COVID. So a big problem with people living with diabetes in the setting of COVID, but we know that diabetics, overall are at risk of infections and other pandemics. Luckily, they didn't. So other coronavirus infections, at least they didn't get to pandemic stage. But we know people with diabetes were prone to more severe disease in those as well.
Yes, thank you, Prof. I've seen in one of your publications that you highlighted the issue of poor control. Was that found that those people with diabetes who were in need of hospitalization and unfortunately sometimes losing their life, were they linked with the control, the quality of the control?
Thank you for that excellent question. In our paper, the A1C was not a predictor of outcome in people living with diabetes. But there does seem to be some conflicting reports from around the world. So there are some reports showing that diabetes control prior to being infected is a determining factor. There's also some data, rather preliminary data, to show that once infected and once admitted to hospital, that better diabetes control does relate to better outcomes. But I think across the board, we know that people living with diabetes who have poor control are more prone to a number of complications. And so I think it just makes sense, especially at this time, to really encourage our patients with diabetes to ensure now that more than ever that their control is good, and that when a person living with diabetes is admitted to hospital, that we then there strive for good control once they are in the hospital.
Thank you, Prof, for that perspective. We have Gina, who is living with type 2 diabetes. She's joining us from Mamelodi in Pretoria. Gina, we would like to hear from you, especially coming out of this pandemic. What has been your challenges affecting care? And in general, how do you cope? And how has been your experience living with type 2 diabetes in South Africa?
Hi, my name is Gina Langa. I'm from Mamelodi in Pretoria. I've been living with diabetes since 2005. What I've learned about diabetic, it's been an honor for me to get help from Professor Danny Van Zyl from the Kalafong Hospital. He encourages me because when I was diagnosed, I thought that was a death sentence. But the prof took me and told me that diabetic is a lifestyle. You need to change your lifestyle. You need to eat healthy. And that's what I've been doing all these years. So what I can tell you is, for now, my sugar, my blood glucose is well controlled. Even if you can ask Danny Van Zyl, he will tell you I'm taking care of myself. So I don't feel any. I'm fine. I'm fine. I'm really fine.
Yes, Gina, we celebrate that. But as you go about living your life with diabetes, do you have any challenges? Is there any problem that you can report to us?
Yeah, the only problem is my feet. I was diagnosed with arthritis 2 weeks ago. That is only my challenge. But so far, I don't have much problems.
Thank you, Gina. We know that the diabetes as a condition, it's really a burden on the person living with diabetes, as well physically as well as mentally. We have Daniel Shear, who is a clinical psychologist, and we would like to explore with him the aspect of mental health and diabetes. Please, Daniel, can you tell us what is the state of mental health services for people living with diabetes in your experience?
Certainly. Thank you very much, Patrick. And thank you to all my co-presenters. It's really an honor to be included in this incredibly important discussion. So mental health care concerns in diabetes, I don't think it's going to be too hard for me to make an argument as to why these need to be considered. But just for those of you who might need convincing, to start with, we know that as people with diabetes, we are at risk, at a greater risk than the general population, of developing psychological conditions such as depression, anxiety disorders, eating disorders, neurocognitive disorders, which includes ADHD and dementia. And on top of these psychiatric comorbidities, we know that as diabetics, we are also at risk of developing diabetes burnout. Now, this in and of itself isn't a psychiatric comorbidity, but it's a very real experience for many diabetics, which influences their motivation. And of course, motivation is one of the factors which underlies behavior. And as many of my co-presenters have alluded to, behavior is a vital factor for us to consider when we think about personal, individual health outcomes and the health on a societal level. So just to reiterate, if mental health conditions and diabetes burnout in people with diabetes go untreated, the research suggests that, well, intuitively, we have a reduced level of well-being and quality of life. This makes sense. It's not fun to have a mental condition. In addition, though, there's research to suggest that people who have these comorbidities are at risk of having poorer adherence, reduced motivation, and ultimately poorer blood sugar control, which of course can then lead to an increased risk of complications, higher expenditure for the individual, increased mortality, and higher expenditure for the society at whole. Now, behavior, what I'm alluding to here, behavior, we need to look at that. And psychology gives us some tools to address that, not only on an individual level, but also on a societal level. However, I would like to agree with my previous presenters and, you know, just reiterate that behavior goes beyond the individual. The personal is political, and we need to think about behavioral change on a multidisciplinary and intersectoral level.
Thank you, Daniel. I'm not familiar with your experience with the public sector. You just painted a picture of the needs of people living with diabetes when it comes to mental health services. Do you think those needs are catered for in the public sector?
Not even close. We have a crisis in South Africa when it comes to mental health care generally. And when it comes to the capacity for diabetic patients in the public sector to access the services that they need from a mental health care perspective, the need, the lack, it's absolutely overwhelming. I truly believe that we need to address this as a matter of absolute urgency.
Thank you, Daniel. Thank you for that perspective. So far, we've discussed the situation painted with some epidemiological numbers. The situation is getting worse. Dr. Dinkelevich showed to us how it's actually stagnating. We have more people with diabetes, but the care is not improving. That's why I want to turn to Dr. Sandeep, who is representing the Society of Endocrinology, Metabolism, and Diabetes in South Africa. They release on a regular basis some guidelines. But we found that the guidelines released by SEMSA are often different by the guideline used by the primary care providers under the National Department of Health in primary care in hospital. Dr. Sandeep, can you explain to us what is that difference? Why are the SEMSA guidelines seems to be often different from what the practice that we found in public facilities? Dr. Sandeep, you are mute. Dr. Sandeep, we still cannot hear you.
Why is it happening?
Good now.
Okay, thank you for the question, Patrick, again. The Endocrine Society's guidelines are an evidence-based guideline on treatment algorithms, and they're very heavily evidence-based, and they give you an approach to standard of care for patients that doctors, researchers, funders, payers, etc. can use, even educators can use, that at least if you follow that, there is safety and standard of care, but it allows for a very nice individualized approach to appropriate therapy.
Dr. Sandeep, sorry to come in there. It seems your voice is a bit soft. If you can maybe please come closer to the microphone or something. Thank you very much.
Yeah, so can you hear me better now? Yeah. Hello, can you hear me?
Perhaps take your headphones out, Dr. Ruda. I don't know if that's the...
Is that better for you?
Just slightly better. Yes, yes.
Okay, it seems to all be connected well here, and I'm on a good line. So, can you?
Yeah, that's better. Great.
Okay.
Yeah.
So, what I was saying is the Endocrine Society's guidelines are evidence-based and give you a standard of care for patient care that doctors, researchers, payers, funders, everyone can use. That if you follow that, you are giving an excellent standard of care. And it also allows flexibility and individualized care if you follow that. The important thing, though, is that you need to know how to use it correctly. And interpretation of guidelines is often an issue. Your question was about how it differs slightly from the public sector. Now, the public sector may be using some government-driven guidelines, and I think in that sector, the cost element becomes a big issue. Then access to medications, which may have better benefits, but maybe more costly, may be an issue. And I think that divide needs to be bridged, where we standardize guidelines for the entire population with an evidence base and be objective in our interpretation of it. So that would be my simple answer to that divide that you highlighted. Patrick, you're on mute.
Thank you for that, Doctor. An aspect that is highlighted by the SEMSA guidelines is the care team, the team-based care approach. Would you like to expand on that?
Okay, thanks, Patrick. You know, when we talk about team-based approach, I mean, so many speakers here have already highlighted the complexity of diabetes, not only in its pathophysiology and the problems the patient faces, but in the causality as well. There's so many macrocosmic environmental issues, whether it's food industry, corporations, sedentary lifestyle, smoking, etc.
Sorry, Dr. Ruda, most people...
And then the complications...
Most people aren't hearing you.
I'm not sure what to do, though.
I know.
Can you hear me now? Yeah.
I'm getting thumbs downs. Are your headphones packed away?
They are, and they're not connected at the moment.
Yeah.
I'll just put that off. They're off.
Oh, okay. Apparently, if you go into your settings, into sound, and turn up the microphone volume, that will help. I mean, again, I want to say there was no chance we weren't going to have any tech issues. I'm amazed we've only had 2 people on mute so far. Do you want to try that, Dr. Ruda? Have we lost you now? Okay, Patrick, I'm going to hand over back to you, and then hopefully when Dr. Ruda comes back, we'll be able to hear him better.
Obviously, those are the issues we have faced with technologies. We'll continue. We got the gist of it. We have Buyelwa, who is with us today, and she is bringing a different perspective. She is the diabetes educator, and we've been discussing the care team aspect. Buyela, please, can you come in here and tell us what has been your experience trying to implement in your facility the interprofessional team-based care? And from your knowledge with the public health system, do you think we are achieving what the guidelines are recommending?
Okay. Hi, thank you. Can you see me?
Yes, we can see you.
Oh, yes. Thank you so much for the invitation. Yes, I'll be talking very briefly about the team approach. I'm just going to touch on why is it important, the evidence-based benefits of team approach, challenges, and of course, strategies to deal with these challenges. Who is in the team, who should be in the team for diabetes management? We all know them, but adding to the obvious, like your endocrinologist, your diabetes educator, dietitian, psychologist, if available, or social worker, that could also depend on an individual because they might have other members members of team that may not be in the hospital or in a clinical situation, like a spiritual healer, or it could even be a traditional healer or a herbalist. So it depends on a person. But in the team, of course, the person living with diabetes is the main person that is in the center of the team. As a diabetes educator, research shows that, a diabetes educator can offer access to education, and that leads to improved glycemic control, improved quality of life, and decreased risk for complications and healthcare costs. Also, research has shown that a team-based approach to diabetes care is an effective way to help people with diabetes manage it well, prevent and treat complications, provide behavior change strategies. And I think that is one of the most important points. And that will also, a team also helps people living with diabetes to cope with the emotional challenges caused by diabetes. Of course, the benefits are many, as we know, including better glycemic control, that I'm repeating that, increased patient follow-up, higher patient satisfaction, low risk for complications of diabetes, improved quality of care, reduced hospitalization, which is very important, and of course, decreased healthcare costs. But what are the challenges? There are many challenges that have been mentioned already, especially here in South Africa. Some of them include access to care, poor reinvestment of diabetes educators, minimal training of healthcare providers, and sometimes people that have been trained, they would rotate in other areas, for instance. And also there could be minimal training and, of course, limited time with patients. And how can these be solved? How can we address these? I think healthcare teams and decision makers, they need to work together to overcome these challenges that have been mentioned.
Thank you.
I'll stop there for now.
Thank you, Buyelwa, for that beautiful pictures. So we see that taking care of a person living with diabetes goes beyond providing medication. We've heard about the need for psychologists, the need for podiatrists, the need for ophthalmologists, specialists. It sounds like that will require a lot of money. But Shivani, please, we know the usual answers, that there's no budget, there's not enough resources. We are in a limited or resources constrained country. But please tell us, what is the cost of inaction? Can we afford not to invest in those professions that we need to take care of people with diabetes?
Hi, Patrick. Thank you for the question, and thank you for the opportunity to be talking to you about this today. I think if we think about investments into healthcare in general, whether we're talking about HIV investments or we're talking about cancer investments, there are very clear frameworks for thinking about it in terms of the economic costs to the country more broadly, in terms of productivity, in terms of the kind of overall impact on us as a country from a well-being and engagement perspective. But also, I think very important to think about the costs of delivering care in a primary care setting and having a very strong focus on prevention and early intervention and good control versus the costs at a tertiary level of dealing with the consequences of poor control. And that investment case in diabetes is exceptionally clear. It's incredibly expensive to be providing tertiary care because of failures in the primary healthcare system. And it's something that we see the increasing impact of. So when we look at the mix of cases coming into tertiary and quaternary facilities, which is the most expensive place to deliver care in our healthcare system, we can see the increasing impact of diabetes, and we can see the increasing impact actually at younger ages. So it's not just a problem. I mean, obviously aging is a huge aspect of it, but we also see an increasing number of patients being admitted into those higher levels of care at much younger ages than we should be seeing. I mean, ideally we should, because diabetes control is possible, diabetes remission is possible. In an ideal situation, we should be seeing close to no diabetes complication cases in an acute setting. And then just to say, I guess, thinking ahead to the kind of NHI and thinking about kind of the long-term costs for our healthcare system, I think very important, what's been highlighted today in terms of not just thinking about financing solutions, but thinking about the investments that are needed into reorganizing care. And particularly the human resources for health shortages that we have. So, just reflecting on what, Daniel was saying about mental health and the critical importance of mental health support as part of a multidisciplinary team. If we look at our shortages of psychologists in South Africa, we have to start thinking creatively about how we maximize those resources. How do we enable access? And how do we really get those multidisciplinary teams working and increase their reach? And I mean, one of my concerns, in terms of the kind of overall policy trajectory, is that something like HRH planning isn't happening on a continuous basis, and it isn't linked to our burden of disease projections and really kind of making sure that we are planning adequately for the future. I mean, just from a burden of disease increase perspective, if you look just at population growth and you look just at the impact of aging, so ignoring all other factors that might drive an increased prevalence of diabetes over time, so just aging and just population growth, we expect to see a 60% increase in the burden of disease. So instead of 5 million people needing treatment, you're talking about 8 million people needing treatment. So that means that not only do we need to be fixing what is not working at the moment, but really thinking very deeply and making investments for the future so that we can deal with that increase in scale and increase in pressure on the system down the line. Because if you don't plan for it at the primary care level, what you're going to need down the line is more acute beds, which is just it doesn't make any sense from a financial perspective.
Thank you, Shivani. So not only fixing the present, but also planning for the future. And one of the actors that have been playing a role into fixing the present in terms of providing screening services, research, has been Prof. Hiede from the University of Pretoria. Prof, please share your experience with the implementation of multidisciplinary research from the University of Pretoria, and personally as a researcher for so many years in the diabetes sphere.
Yeah, thanks, Patrick. I trust I'm unmuted now.
Yes, we can hear you.
So Patrick, I think that we had a huge opportunity. I think a lot of people, I know Professor Levitt and Professor Joel Dave well as well. Professor Mash, I see, is also here. So all my colleagues from Cape Town, Stellenbosch and Wits, we've been working together in the field of diabetes for probably the last 2 to 3 decades already. And so, yes, so I think there's a lot of great stuff happening in various centers around the country. And we've been fortunate at the University of Pretoria that we've also been working in diabetes in many fields. So, for example, in gestational diabetes, we've got a very strong group working in gestational diabetes. We have a very strong interest in primary care diabetes related to the work of Professor Jannie Hugo in family medicine, together with the School of Public Health. So we've got one of the few, I think, unique collaborations between the Department of Internal Medicine, which runs the academic diabetes clinic here at Steve Biko and Kalafong hospitals, who work together with our primary care colleagues, because we are very concerned about being the sort of the receivers of a failing healthcare system or failing healthcare delivery when we end up seeing those patients with complications. So we have found it to actually be very rewarding to collaborate in primary care to improve the care that patients are getting at primary care clinic level. So those are some of the things that we've been working on. Also, I mean, the whole issue of technology, telehealth, some of our interventions, we're trying to sort of link a telehealth application to the local clinic and the local family medicine practitioner located in the clinic. So working together with clinic nurses using digital or telehealth apps, linking it to the family medicine physician. So that interaction between, basic good healthcare, but trying to access technology as well to improve that. So there have been a number of things that we're looking at. We had a very exciting project later this year where we engaged with the Department of Marketing Management, where we actually involved some postgraduate students to come up with some novel ideas regarding how to actually help us in the sense of advocacy at local level in the communities when it comes to dispelling insulin myths, for example, and sort of accessing comprehensive care. So we think that patients should be empowered to realize that good care consists of a couple of elements, and if they then go to the clinics expecting that care, that their care should then improve. So we've involved, as I said, some other disciplines as well. So I think there's a lot of opportunity, and we're quite excited to take this forward going into the future.
Thank you, Prof. I like the point you raised about patient employment, and for the past the recent years, we've seen the role that technology can play in terms of empowering the patient, and I'm talking about continuous glucose monitoring. Prof. Dave, from your experience, how can we integrate technology to improve care in South Africa? Prof. Dave, your mic is mute. Thank you.
Thanks, Patrick. Thanks very much for that question. I think we're living in exciting times because there is improving technology around that definitely now an evidence base showing how it does help to improve care. The two major technologies are continuous glucose monitors and telemedicine, telehealth. The problem that we face in South Africa, I think, and especially in the public sector, is the cost of this new technology and the numbers of people that we need to access it. I think this alliance is a fantastic venture, and hopefully it's going to become an active lobby group, almost akin to something like the Treatment Action Campaign that initially in the HIV world, where things were unaffordable, a lot of lobbying and advocacy resulted in things becoming more accessible to many more people. So I think continuous glucose monitors especially have the capacity to improve diabetes control. They have the capacity to improve morbidity and mortality, and certainly if you speak to many people living with diabetes, certainly from a quality of life point of view, continuous glucose monitors really make an impact. So I think that's one of the technologies, together with ventures in telehealth, where we can really make an impact on the morbidity and mortality of people living with diabetes, and especially those accessing their health in the public sector.
Thank you, Prof. Daniel, as a clinical psychologist, I would assume you spend quite, and a person living with diabetes yourself, I would assume you spend a lot of time with people with diabetes. What would you say are the priorities we should focus on for the diabetes in general, obviously from your perspective as a person living with diabetes, as well as a psychologist?
Thank you, Patrick. Look, I'd like to stay within my lane here, but I definitely agree with what Prof. Dave has been saying, just in terms of, my own anecdotal observations of my patients. And, as a type 1 diabetic myself, I've seen the change, the impact on quality of life that having access to continuous glucose monitoring technology can have. And of course, this is anecdotal, but the difference was immense. And I've seen this difference replicated in the lives of my patients. And of course, there's so many different things that we need to look at. But I do believe that access to technology is also going to speak to psychological well-being. Above and beyond that, I think, there's a consensus in the literature, the global literature, that mental health screening needs to be happening as a matter of routine. And obviously, the people who are conducting that screening need to also be empowered to act on positive results from that screening process and have systems and networks, referral networks to whom they can rely upon for support in helping these patients.
Thank you, Daniel. My colleague Susan has been keeping an eye on the questions that you guys are asking all over the world. We want to see, Susan, is there anything you want to bring to the panel, please?
Hi, Patrick. Good morning. Hi, everyone, to the panelists. Thank you so much for your time. My name is Suzanne. I'm a type 1 diabetic for 25 years. I've been looking at the questions and there's a few really great ones. I think the first one is we just want to check if Dr. Ruder, if the audio is better now, because there's been a few questions for him to just repeat some of the things he said. So, for example, how the SEMSA guidelines are different to primary care guidelines, and what has he found to be the most impactful approach to empower people with diabetes to manage their own care. But I'm not sure if the audio is better now.
Hi, Suzanne, can you hear me?
Yeah. We can hear you perfect, Doctor. Take it away, please.
That's great.
I'll leave my video off. I'll leave my video off to save bandwidth. I'm not sure what's going on. But thank you for the question. I hope you can hear me clearly. Just to get to the gist of the question, so SEMSA has very, very good evidence to spectrum, and it allows for individualized care. The main thing about our guideline is that if it's followed, you are giving an excellent quality or standard of care and safety for the patient. But it's not preclusive in that you can allow the practitioner who understands the guideline to approach it with an individualized care approach, which is very necessary in diabetes today. I mean, you've heard of a lot of technological advancements in the treatment space, with cardiovascular risk, etc., being a major issue. So SEMSA's guidelines accounts for all of that. The difference with the public sector guideline may be due to the fact that cost in the public sector is a major issue. And that may then downplay the role of certain treatment options that may be more necessary. So the discussion that needs to be had is one on standardization of guidelines across the board. And this is a discussion that comes down to equality in healthcare and justice, etc. But having said that, our guideline, the Endocrine Society's one, is very thoroughly investigated. And I know the committees that did the work, the evidence-based case, excellent in there. The evidence base is excellent. So we need to have, and I think it's great that with the Alliance, we can maybe sit at the same table and look at standardizing this care. The other important part about the guideline, I just want to mention while you got a good quality bandwidth here, is that the guidelines we see locally and around the world are perhaps, and importantly so, treatment heavy. So we have a lot on the drugs and the evidence based on drugs, but you'll see that in the chat box and everyone's talks, that lifestyle and the environment and perhaps not getting the emphasis they need. And you may have lost me for a second. So I think the guidelines need to amplify the roles of the educators, the lifestyle practitioners. Dr. Pillay used the words life course. And we need to maybe have a guideline for how to live life correctly if we're going to start talking about preventing diabetes and treating it properly. Patrick, one point I also want to make is, in the last 20 to 30 years, there have been rapid advancements in the treatment of diabetes. So we got technologies that are excellent. You see CGMs, newer insulins, analogs. We got cardiovascular protective drugs. But when you look at the actual data, the dent we're making on treatment goals, which are defined in guidelines, is very little. And it's been shown very scientifically and academically that the biggest issue still remains adherence, compliance, and lifestyle, So when you think about root cause issues, when you got technology that's improving, but outcomes are not really improving, then there's that human behavioral component. And I think that question needs to come out in academia, where we have a very chemical biological approach to developing guidelines, to perhaps look at this behavioral component from a more psycho-moral, and perhaps even in some aspects, religious, spiritual kind of approach. Like, what is the point of human life? We're getting diabetes or type 2 diabetes in the pursuit of happiness. Nobody goes out there to smoke or drink bad things to get diabetes. We're doing it in the pursuit of happiness. So that relationship with the world is where we need to perhaps focus some of our investigation and think about a guideline for that on how to think about things. So that's just broadly some of the comments I wanted to make for the sake of time, but I'll take any other specific questions as well.
Thank you, Doctor. I think there's a follow-up question that I think is perhaps a good time to ask now is someone asked whether these guidelines are filtered down to practitioners, and do all practitioners upskill and make the effort to keep up to date with guidelines? A part of me thinks I can answer that question.
Yeah, so the SAMHSA guidelines are widely available and distributed when they are done, and I know the government guidelines as well. We have always, and Prof. Joel Dave will attest to this, through various avenues, done training in guidelines and made it as accessible as possible. I mean, you can Google it and download it for free from the SAMHSA website in a PDF format. So they are accessible. I think, we always make the point that you can have a lot of knowledge and information, but how to use it requires training. And one of the points Patrick had raised in discussion we had is, should there be some accountability when using guidelines? And I don't think, you see, if a practitioner can use an evidence base to confirm why he's used a certain treatment approach, you can't hold someone accountable to a guideline. A guideline is just a guide for safety and standard of care, And I think that's important. What's more important is to train more doctors and primary healthcare practitioners on how to think about the issues and then objectively approach the patient in front of you individually. While policy, environment, government provide the resources to allow us to do that, the individual care is between the patient and the doctor, and that's called the art of medicine. We've got to hear our patients. There's one of the ethical principles is autonomy in care. So that allows the patient to his own critical thinking to discuss treatment options with the patient. So guidelines are not a doctrine. They just provide, in a very complex world, a standard that provides safety and good evidence base, but you can play around in them depending on the individual need.
Thank you so much, Doctor. And then we have a vaccination question. I believe this is for Professor Dave. So I think the question is around what are sort of the statistics around diabetics, people living with diabetes and vaccinations, and what are the barriers in terms of people going for their vaccination? And then sort of thirdly, what can we do to improve that number?
Thanks very much, Suzanne, for that very essential question. I'm not aware of any studies that have been published specifically on showing the reduction of or the efficacy of the vaccine in people living with diabetes. But if you look globally at, and especially at countries that have got high uptake of vaccination, the mortality across the board is vastly reduced. So the mortality across all comorbidities and all age groups. So there's no doubt that vaccination and, in my opinion, all the vaccines have a major effect in reducing the severity of COVID-19 across all comorbidities and age groups. It doesn't really decrease your risk of getting infected, but there's no doubt that the risk of severe disease and especially mortality is reduced across all age groups and comorbidities. There actually shouldn't at this moment in time be any barrier for anyone to go and get a vaccine, especially someone living with diabetes. In the beginning, when vaccines were a bit hard to come by, there were barriers then, but at this moment in time, there's actually no barrier within South Africa. Let me add, unfortunately, in South Africa, for any person living with diabetes to go and get vaccinated, and everyone over 12 years of age should actually now go and get vaccinated. There's no doubt that if you have a look just across the world and at population data, that vaccination is decreasing the severity of COVID across everyone. In those that are not going to get vaccinated, well, that's a difficult question, and I'm going to pass the buck to Daniel, because Daniel's got a much better understanding of how we try and convince people, whether it's some type of motivational approach or some type of fear-mongering approach, to try and get everyone who at this moment in time doesn't want to get vaccinated to actually change their mind and to go and get vaccinated. Sorry, well, Daniel.
Thank you for that, Prof. There's no pressure on that one, evidently. Like, it's such a huge question, and I won't pretend that I have the answer to it, but it's clearly something that we're needing to work towards, a better understanding of how to motivate for behavior change, which on an individual level, I suppose, comes down to finding a balance, striking a balance between making a person aware of the possible consequences of acting or not acting in a particular way. So whether we think about, vaccinations or diabetes management, versus leaving them feeling that they know the way forward, leaving them feeling empowered about their capacity to act in a way which is going to improve their health. So that obviously is a very vague statement, and there's no clear advice from me on how to move forward from that. But certainly, again, I'd like to reiterate what's coming up in the chats and what so many of my co-presenters have alluded to. We need to think about education. We need to think about access to these services, and certainly, I believe, if we think about primary healthcare workers, if we think about community healthcare workers, if we're empowering them to stage these interventions, I think that's a really good way to start.
Thank you so much, Dr. Sher. Patrick, is there still room for a few questions?
Yes, maybe one or two.
Okay, I think while we have Dr. Sher on the line, good morning. I have another question from you. I think the mental health issue or challenges are so huge that people are very grateful that you're on the line. The question is, what ways are there in which we can assist, especially I think in the public health sector, with mental health care? Because a lot of people has already said, there's a lack. I think there's agreement in terms of that, but how do we solve this? What are some of the ways that we can have an immediate response?
Thank you, Suzanne. And yeah, what a fantastic question. And you know, I've been watching the chats and I've been watching what Prof. Mash has been speaking about, which is he's been mentioning, you know, interventions which have aimed at empowering the healthcare workers that do exist in the public sector to be facilitating and providing these sorts of behavioral interventions. And, you know, I'm just speaking from my, again, anecdotally and from my personal observations here, but it really sounds like that's where the focus needs to be, because in the public sector, there is a massive shortage of allied healthcare workers who, and a massive, you know, that they're so overwhelmed, those who are there. We need people who are, we need these skills to be essentially distributed to a broader network of healthcare practitioners in order to make all of this, all of the mental health care benefits of diabetes-focused treatment more accessible.
Cool. Thank you so much. And I think then, lastly, I think we have opportunity for one last question. There was an important question that I believe speaks to stigma around especially type 2 diabetes. One of the people asked, said that 1 in 3 Americans are said to be obese, but only 1 in 10 are diabetic. So the individual then asked, can you be obese and not diabetic? And what are the roles of genetics and exercise, etc.? And I think there's a lot of people who struggle with that question. Patrick, I'm not sure who on the panel I should direct this to.
Try with Buyelwa. She's been very working closely with the patient. She might know about how to deal with stigma and those aspects that you were raising.
Cool. Thank you.
Buyela, your microphone is mute. Buyela, your microphone. Okay, yes. That's good. Yeah.
Can you hear me now? Am I on now? Okay. Well, stigma, I mean, if I look back and during the times of when HIV/AIDS came initially, it was very difficult for the people to come up, you know, and say they have diabetes. And so I think having other people with diabetes, especially when people are newly diagnosed, to talk and have support groups, and having the people with diabetes helping the others, it would I would take that approach. And also also in having these group sessions when patients, let's say, for instance, with Bob Match, a great project where the patients come together in the clinic and having these sessions, these group sessions, that helps a lot of issues, from stigma to management to finding solutions to their challenges. So I think that would be the approach. Group sessions with people with diabetes, and of course, those sessions obviously should be led by people with great communication skills that are non-judgmental, that will help empower people living with diabetes, accepting it, and actually helping others as well. I think that would be my approach.
Thank you.
Thank you very much. Patrick, am I out of time now?
I spotted a question about investments in the public sector. I don't know if you saw that question. I think in broadly, Shivani, maybe you can tell us what are the strategies that the National Department of Health can use to maybe increase investment for NCD in general and diabetes in particular.
Patrick, so I mean, one of the very first things that's necessary is to put together a proper investment case that can be taken to National Treasury. So this has recently been a similar one done on cancer, which really requires thinking through the service delivery design. So what is it that is required to actually put together you know, like a mechanism for dealing with diabetes and across the cascade. So, you know, what are all of the different components that are required? And to the question earlier about what the costs are, so if we made the proper investment in good primary care and in early intervention, what would the trade-offs be and the kind of potential cost savings? So to put that investment case together, which includes projections forward, it includes looking at what we think is going to happen to the burden of disease, so that all of that is actually kind of articulated and well supported and well evidenced. Then, I mean, obviously, in the fiscally constrained environment, not all of those resources will necessarily be available. So it's then thinking about priorities and where to begin investment. And I think, I mean, the other, so that's kind of looking at diabetes specifically. Obviously, there are all of these interconnections between diabetes and other conditions. And I think in an investment case, it's useful to think about that as well. Because certainly the consequences of investing in approaching care in the right sort of way, and thinking in a whole of society way would have implications beyond the direct implications for diabetes. And then I think there's, from a National Department of Health perspective, there's enormous investment that's required in the planning capabilities. So really going back to the point about planning for human resources for health. Planning for the burden of disease, making sure that all of these capabilities are actually built out to be able to support the rollout over time. And that links to having a clear strategy, so what are the goals, what are the targets, and then what investment is required in order to meet those targets. I think often the targets and things are set, but without consideration for how it is that we're actually going to release the resources to be able to deliver on those targets. So both of those things need to be happening together with that kind of long-term planning capability, technical capability.
Thank you, Shivani. I've picked from the questions and the comments that despite the use of technology in the US, the care is not still optimal and actually kind of worsening. Prof. Paul here, please, can you tell us what type of strategies you've been exploring in terms of improving care in primary care as well as in hospital sector level?
To whom is that question addressed?
It's to Prof. Rieder. Yes, Prof?
Yeah. Sorry, Patrick, my mic did not want to unmute. Can you hear me now?
Yes, we can hear you, Prof.
Yeah, so Patrick, I think a couple of things are important. I mean, many people have sort of indirectly maybe alluded to that. I think it's key that we have some key indicators that are measured across the country, in all provinces and in all districts. Those key indicators, let's take HbA1c as an example. I think some of the speakers had mentioned that only 20% of patients had HbA1cs measured. I think that is picking up countrywide, and most certainly in our district and in our province, that has increased quite significantly, I think, in the last year or two. But if you take something simple like the HbA1c and you focus on some key indicators, HbA1c, some lipid value, some protein in the urine value, creatinine value, and then some complication screening indicator, like a foot exam, eye screening, nephropathy screening, etc. And we all agree on what those 6 or 7 key indicators are. And we actually monitor the outcomes on those indicators on a district and on a local clinic and on a district level. Then I think we can actually act. But unless we have those figures, we're basically just in the dark. So every now and then, some university clinic or some university will do a study, be it at the clinic level or in the community. But we do not have good aggregated South African data given to us frequently on a quarterly basis, so that we actually know what blood pressure, glucose, and lipid control looks like at a clinic and a district level. So I think that's something we're really working hard at locally in our district, is to make sure that those indicators are standardized and that is what's audited with clinic audits, because all the provinces actually do run audits at local clinics. So I think this is something that we can most certainly utilize. The guidelines are there. I mean, we can have many discussions about what care is available. I most certainly agree that the education is severely lacking, and that helping patients cope with their disease, helping patients manage their disease themselves, those are all key aspects to care. But I think unless you have clear goals and strategies how to reach those goals, it will remain a challenge. So I think those are some of the things that we focus on, and I think we should have a national strategy of identifying some key variables and see to it that they actually happen.
Thank you, Prof.
Patrick, there was a question or a couple of questions around podiatry and screening, and the specific question was that the pandemic has obviously disrupted diabetes care programs all across the world, and what is the current situation in South Africa in terms of podiatry care?
That's a very good question. From personal experience, and I've discussed with a colleague that works in podiatry in the public sector. First of all, foot care is the #1 complication in diabetes in sub-Saharan South Africa, including South Africa. Unfortunately, access to services such as podiatry or a simple thing like a foot exam is not happening. It's really a big gap. And my colleague who works at the podiatry department in the public sector told me that actually with the COVID-19 pandemic, her patients were not coming to the clinic. So once the lockdown stopped, she started receiving patients with foot that were really feet that are complicated, and that some of them needed amputation. But I want to give it to the panel. I don't know if there's anyone who has had that experience with foot care. Maybe Prof. Dave in your center in Cape Town.
Thank you, Patrick, for that question. And it's quite pertinent that it's asked at this time because in line with World Diabetes Day on Monday the 15th, we've managed to luckily get funding to open a diabetes center here at Groote. And part of the diabetes center is going to be a foot center where we're going to hopefully have a multidisciplinary team looking after the many foot problems that we do experience here in the Western Cape with amputations at an all-time high. So I think the person probably who knows more about this is Professor Levitt, because she has published on amputations here in the Western Cape. But it's no doubt, just anecdotally, if you speak to the surgeons, weekly there are amputations, many amputations. And the sadness is that all of this can be prevented. So the diabetic foot ulcer can be prevented, and thereafter all the complications downstream can be prevented. So I'm hoping that maybe if I'm invited to the summit again in a year or two, I'll be able to report some good news that our foot center here in our diabetes center has managed to make a significant impact on the reduction of diabetic foot ulcers and also amputations.
Prof. Levitt, would you like to add something to that?
Thank you very much. Thanks, Joel, and thanks for the opportunity to comment. We have done work in the past which showed that diabetes is the most common cause of non-traumatic amputations. We also are totally and utterly aware of the fact that there are just about no podiatrists within the public sector. And so I think that if we look at a stratified approach, the first approach we need is for people, every person attending primary care clinic for diabetes should have a foot examination once a year to identify whether they have an at-risk foot or not. We then need a referral pathway in order to deal with those who have at-risk feet. Ulcers are way down the line. We should be preventing all of these things. We should be preventing ulcers and we should be preventing amputations. And I do believe that we need a coordinated program in order to achieve this. We have had numerous workshops in the primary care setting over the past years to train people, train nurses and nurse associates as to how to examine feet. You don't need to be a doctor to examine a person's foot. if we think about a team approach to diabetes healthcare, each person has their role. You could have a community health worker who is trained, or a peer supporter who is trained to examine people's feet. And that, I believe, would have an enormous impact on amputations in our society. They are entirely preventable. And it's unforgivable when we see young people with bilateral below-knee amputations because of diabetes. Cut down, at the most, productive time of people's lives. Thank you.
Thank you. I'm happy in the conversation. We've seen and we've learned that the approach to improve diabetes care and actually to improve the life of people with diabetes is quite complex. But it's a team approach that can make us win. It's important, as Prof. Levitt said, each person has a role to play. But we need to play that role. That's why us as advocates, as researchers, as clinicians, we are raising our hands and we're saying, as the International Diabetes Federation is saying, if not now, when? Access to optimal diabetes care, if not now, when? Thank you for all the panelists. Thank you for the great discussion and for all who followed us this morning. I will give it back to Titi for the rest of the program.
Oh, thank you so much. Thank you so much, Dr. Patrick, for facilitating that conversation, and to the panel, to everybody who was involved and giving us their expertise, their answers, and so on and so forth. Thank you so much to everybody, man. We're halfway through the whole program. So what we need right now is for everybody to make sure that they get up, stand up, get up, shake yourself off, stretch a little bit, get a little bit of water. Let's shake it off, and be fresh, because we're about to go into the last stretch of the program, and we're about to end things off. But it's going to be really, really, really super. Right now, we're going to go to the Mentimeter questions. Mentimeter questions. Don't forget that you can answer those questions that we're going to ask to you. All you need to do is scan that code right there. Okay, that's the code that you need to scan and be a part of it. We need you to answer these questions, and we're gonna have the answers just pop up of what you have to say. Now, we're about to share some highlights from the workstream reports with you. As a reminder, these are 5 work streams that are centered around the themes in alignment with the World Health Organization Global Diabetes Compact. We want to know, which theme are you most excited to hear about? Which theme are you most excited to hear about? Awareness and prevention, education, management and access to care, surveillance, innovation, and research. Let's go through that again. Awareness and prevention, education, management and access to care, surveillance, innovation, and research. Now, those are your options, and we will see the answers pop up as you answer them. I think we have about 500 people online right now. Crazy numbers. Thank you for taking your time. 506, my bad. People online right now. Thank you for taking your time to be with us this morning for this very important, conversation. Very important things that we're sharing amongst each other. Ahead of the Diabetes Summit, a diabetes charter was created by volunteer collaborative work streams with input from top diabetes experts. Members of the Diabetes Alliance and any other members of the public, including many people living with diabetes, volunteered to be a part of these work streams and did a deep dive into their theme, right? A representative for each work stream will now present on the evidence-led challenges and proposed solutions with their specific themes. First up, we'll be hearing from Alexandra van Es, who will be outlining the challenges and proposed solutions from the awareness and prevention work stream.
My name is Alexandra van Esch. I am a type 1 diabetic, and I've been living with diabetes since the age of 5. And I'm now 54, so living with diabetes for 49 years. I'm presenting the awareness and prevention work stream. We've spent a lot of time workshopping this, and we've come up with very succinct challenges as well as proposed solutions. Kicking off with the challenges, half of people with diabetes are undiagnosed. So in other words, half of South Africans who have diabetes don't know about it. Okay, next challenge. There's a very high prevalence of diabetes. 2 in 3 people in South Africa will develop type 2 diabetes if nothing is done. Another challenge. Gestational diabetes has been shown to progress to type 2 diabetes in roughly 50% of cases within 5 years. Next challenge, a critical challenge, the lack of awareness. There's a low awareness of symptoms and risks. People are walking around, they're thirsty, they're tired, their feet are burning, their vision's becoming blurred, and they're not realizing that these are the critical symptoms of diabetes amongst other symptoms. There's a limited awareness of pre-diabetes amongst healthcare professionals. Critically, the link between obesity and diabetes is not being clearly linked. Food insecurity. People don't have enough food, they don't have enough healthy food, they don't have access to food. 20% of South African households has inadequate or severely inadequate access to food. Type 2 diabetes stigma. I think there's some stigma with type 1s as well. But an international study showed that 84% of participants indicated they believed type 2 diabetes was stigmatized. Right, having presented the challenges, we are now going to present our proposed solutions. First solution, screening to reach at-risk South Africans through the primary healthcare system, public and private. And critically, if you're going to screen, those that test positive or those that are at risk need to be linked to care and linked to services to support them and treat them. We're doing it with HIV. We've got linked to care officers out in districts. We need the same for diabetes. Risk factor awareness, okay? In this, we need to consider South Africa's varied and diverse population, and messages need to be tailored towards each different population group, as well as age groups within those groups. Critically, these messages need to connect gestational diabetes as a risk factor for developing type 2 diabetes. We need to connect obesity as a risk factor. And in disseminating messages and raising awareness, we need a whole of society approach to provide a nurturing environment for behavior change and action. Increased non-communicable diseases awareness. In order to do this, we need a multi-sectoral approach. No one person, no one stakeholder, no one group can do it on their own. Media and schools, we've got to address stigma related to type 1 and type 2. We've got to send out the positive messages as captured in previous slides. In order to do this, we need the media, and critically, let's start in schools. That's where a lot of the initial messages and the initial learning around diabetes, diabetes awareness, diabetes prevention can start. A diabetes portal, it's one of our solutions. We did it for COVID in a very short amount of time. And if you look at that portal now, it is a hub of rich information that's got information for scientists, technical people, as well as beautiful information for the layperson and for ordinary South Africans. We need the same for diabetes. Last solution, money talks, increase the health promotion levy. This could work at scale to shift behavior by economic rather than educational means. And this levy has been proven to reduce harmful behaviors. That is our last solution. Thank you for your time.
All right. Thank you so much for that. That was very, very informative. Some of the things that I had no idea about. But we're going to move next. We'll be hearing from Piti Dipela, who will be explaining the challenges and proposed solutions from the education work stream.
Good morning. My name is Piti Dipela. I'm a qualified dietitian. I've been working together with the team on the education work stream. And some of the challenges that we found on the education work stream that are making diabetes education a challenge in South Africa. Number one is lack of access to quality. Number one is lack of access to cohesive quality diabetes education in South Africa. Diabetes education is a major problem in both the public and private sector. So there isn't any standardized diabetes education programs. And if they are available, the current material is usually written in English. And so this means it increases the risk of inadequate quality health literacy, where diabetes education is given once off only at diagnosis and there isn't follow-up education. The second challenge that we've come across is limited diabetes nurse educator positions, especially in the public sector. And that is where most of people living with diabetes receive their care. So the role of diabetes nurse educator is not recognized within the SACA accreditation. And for people living with diabetes, education and support are one of the major primary treatments. The third challenge that we've come across is lack of ongoing support. Diabetes is a self-managed condition, so meaning that it requires support from people living with diabetes and also their family. But often people living with diabetes are not informed about the management of diabetes. And not all people living with diabetes have access to resources like internet and social media. So healthcare providers are often not trained specifically in diabetes management. The fourth one is service provision. The fourth challenge that we've come across is service provision. Many healthcare providers in the public sector are working in already severely under-resourced and understaffed facilities. So as a result, it makes diabetes education not their priority. Right, so we've come across proposed solutions in order for diabetes education not to remain a challenge in South Africa. So the first one that we've come across is a cohesive diabetes education. So there needs to be a more standardized education programs that is easy to understand. We also need a more structured, tiered framework from prevention information to the basics of diagnosis. Diabetes education material also needs to be available in home languages so that it's better to understand for those people that are living with diabetes. The second proposed solution that we've come across is diabetes nurse educator positions that need to be available at primary healthcare level. There's a critical need for the South African Nursing Council to recognize the speciality of diabetes education. If the diabetic nurse educator role can be formalized, regulated, and recognized, that would prompt incorporation of the role into guidelines. And this is not a suggestion to introduce a verticalized care, but is rather to support a more comprehensive integrated approach for the health service. The third proposed solution that we've come across is ongoing support. There needs to be a WhatsApp-based diabetes education. Diabetes education not only rely on the pamphlets. Mobile penetration is quite significant. And with a WhatsApp-based diabetes education, it could be one part of the solution. And of course, this would also be zero rated so that no costs are involved. And then when we have a WhatsApp-based diabetes education, it should also be expanded in home languages that is easy to understand. Another essential part of diabetes education is shining the spotlight on diabetes distress. People living with diabetes often experience feelings of distress, guilt, and denial. And so an actual approach is fundamental. The fourth proposed solution that we've come upon is service provision. A multidisciplinary approach is necessary and essential for diabetes education, where various service providers must be included. And more access to diabetes education management courses should also be available for healthcare providers. Diabetes nurse education need to be a specialist track for healthcare providers and other clinicians as well. Diabetes centers could also be considered as a long-term solution where it will give healthcare providers the opportunity to diagnose and manage diabetes at a primary care level instead of referring to tertiary institution for management. Thank you.
I think you're on mute, Titi.
Oh, yes. There we go. Okay. Technology. It's giving us a problem. Don't forget to download the Diabetes Charter on www.diabetesalliance.org.za to get all of that information. That's the Diabetes Charter on www.diabetesalliance.org.za. Now, what are the challenges and proposed solutions when it comes to management and access to care? Sane Mazibuko will outline those for us in the next video.
Hello, my name is Sane Mazibuko and I'm a type 1 diabetic and have been for the past 25 years. The work stream that I will be talking about is the management and access to care. I'll be presenting the challenges as well as some of the proposed solutions that we have identified. The first challenge that we've identified is poor levels of care. And in this, I personally have had access to both the private as well as the public healthcare system. And in that, I can attest to the fact that there's just not enough monitoring and screening for complications and comorbidities. For an example, in my 25 years of being a diabetic, I don't remember once seeing a podiatrist in the public space. I do have complications. So I've had eyesight issues, and I've never been screened for my eyesight when I did not have the access to the private healthcare sector. So there's definitely there's poor level of care, particularly in the public healthcare sector that needs to be taken care of. And also there's the lack of continuity in terms of who's attending to you as a person with living with diabetes. There's no that consistency in seeing the same doctor or seeing the same nurse that will understand your case file and take care of you in all instances. So there's definitely a need for a better level of care, just holistically across the board. Lack of monitoring. I think in the South African context, we do know that there's more type 2 diabetes than there are type 1 diabetics. In that, we also noted that there's lack of provision for the right monitoring tools to give support and be able to continuously monitor how one is doing. Again, going back to the public health sector, I don't remember once ever getting line of sight of what my HB1AC was in that space. So again, that lack of of continuity, in terms of seeing the trends on how a person's sugars are behaving through time is not there. And then that also then means that in the long-term effects, there's no adjustments that are made, the correct adjustments that are made to in terms of medication, bearing in mind that our bodies are continuously changing, and there's a continuous need for us to be able to change and be up to date in terms of the medication that we have. Another point that we highlighted was that there's a challenge around the standards of key processes. For an example, HCP's compliance to standards of key processes of diabetic care and glycemic control have been found to be poor. The pervasive poor glycemic control signifies that the risk of microvascular complications is substantial, while cardiovascular risk factors such as hypertension and hyperlipidemia are highly prevalent, but also suboptimally managed. Research has also shown an increase in diabetes-related lower limbs amputation. We're not only highlighting the challenges, but we've also put forward some proposed solutions with regards to the challenges that we've highlighted. First one being that there's definitely a need for changes to be done within the current delivery of diabetes care. In that, we're saying that key processes and outcome indicators need to be advocated and then audited regularly with feedback to clinics regarding their performance. Primary care HCPs need to be trained about these goals. Medication options need to be standardized, and more intensive alternative interventions triggered by higher HbA1c. There's definitely a need for integrated, there's definitely a need for provision of integrated care. In that there needs to be, we say that there needs to be annual reviews, introduction of targets with feedback loop, structured education programs to enhance self-management. So we're not only empowering the healthcare professionals, but we're also empowering the patients themselves so that they're able to look after themselves as well. Uninterrupted access to medication and monitoring, and access to mental health services is very, very vital. Management of type 2 diabetes. Guidelines need to outline a distinct time limit for which glycemic targets should be met once a person with diabetes has been initiated on oral medication or insulin. There's definitely a need to prioritize access to blood glucose meters and test strips, as well as training healthcare professionals to understand and interpret self-monitoring blood glucose. Individualized approach to diabetes therapy, bearing in mind that no two cases of diabetes are the same, and so we need to have an individualized approach to this. And this also includes comorbidities, and the integrated chronic disease management model is an innovative vehicle for this.
You're on mute again, Titi.
There we go. Thank you so much. Very, very informative from Sane Mazibugo. Of course, you can download the Diabetes Charter on www.diabetesalliance.org.za. Make sure that you go down there and you download the Diabetes Charter. And up next, we have Kathy, who will explain the challenges and propose solutions from the surveillance work stream. Let's check it out.
I'm Kathy Haldane. I'm from FIND, the Foundation for Innovative New Diagnostics, on the NCD team. And it's my pleasure to, on behalf of the surveillance work stream, represent the challenges and proposed solutions for surveillance in South Africa for diabetes. As described by the World Health Organization, public health surveillance is the continuous systematic collection, analysis, and interpretation of health-related data. It is essential to determine the public health impact of disease by monitoring the burden of disease and disease trends, mortality and morbidity, enabling monitoring and evaluation of the impact of an intervention, tracking progress towards specific goals, guiding priority setting, planning, and evaluating public health policy and strategies. Surveillance methods include national health surveys, registries, and electronic health records. Registries are a necessary first step towards improving the quality of care. We provide a summary of the challenges related to surveillance in South Africa. Firstly, there is limited regular surveillance for diabetes in South Africa. However, several surveys have been conducted periodically that collect data on non-communicable diseases and their risk factors. These include the South African Demographic and Health Survey and the South African National Health and Nutrition Examination Survey. However, the surveys tend to be once-off and do not use standardized and comparable methodology. In addition, surveys don't provide for a differential between type 1 and type 2 diabetes or other types of diabetes. There is a significant data gap, particularly in the public sector. According to the International Diabetes Federation, there are an estimated 1,600 children and adolescents with type 1 diabetes in South Africa. However, data from the Council for Medical Schemes indicates a treated number of just over 4,200 children and adolescents with type 1 diabetes within the privately insured population of South Africa, which we know represents just over 16% of the population. So the total number of children and adolescents with type 1 diabetes is likely to be considerably higher than the 1,600, but there's no accurate data for the public sector, where the majority of people with type 1 diabetes are likely to receive their care. There is no South Africa registry for diabetes. Registries exist for cancer, HIV, and TB. There is no registry for diabetes in South Africa, even though diabetes is an ideal condition for a registry-based system, since it is so clearly a data-driven condition. We are excited to have the opportunity to share proposed solutions that are aligned with the South African National Strategic Plan for Non-Communicable Diseases, specifically Goal 4, which relates to building health infrastructure for effective service delivery and robust and effective health information systems to improve evidence-based decision-making. Also in alignment with Pillar 9, which is to develop an information system that will guide health system policies, strategies, and investment. The proposed action steps. Firstly, would be to prioritize the establishment of a national diabetes surveillance program. The surveillance program should be informed by national diabetes policy and guidelines that are based on evidence-based medicine and health economic outcome analysis. Secondly, is to establish and publish a standardized data set of measurements for type 1 and type 2 diabetes to be adopted for surveillance in South Africa. This would need to be defined and developed by a representative group. Thirdly, is to create a diabetes registry with standardized data to be collected annually to assess levels of control and complications. This would also enable assessment of complications and the impact of intervention on complication reduction. Fourthly, is to conduct a 5-yearly demographic and health survey to assess the prevalence of diabetes, to provide dedicated resources and investment for diabetes surveillance program development and ongoing implementation. It's important to ensure that the surveillance program is independent and free from commercial involvement and political interference. Funding could be distributed to coordinate the establishment of a registry through all South African academic centres. Encourage and support stakeholder engagement across all levels of the healthcare system to ensure adoption and implementation. Include surveillance in the education and training of healthcare workers at all levels. to consider leveraging existing surveillance systems and enhancing them to include diabetes surveillance. An example is the current surveillance system used for HIV. And lastly, to support the mandate of the National Public Health Institute of South Africa, as described in the Gazette, which is to coordinate and, where appropriate, to conduct disease surveillance, to provide public health interventions, training and research directed towards the major health challenges affecting the population of South Africa. So in conclusion, the optimal management of diabetes requires a coordinated approach from a range of healthcare professionals, including access to medicine, technologies, and a system that supports empowerment of people living with diabetes. Diabetes could serve as a tracer condition for the strength of the national response to non-communicable diseases. Establishing a national diabetes surveillance program based on a standardized data set of measures for diabetes will lay the foundation for the coordinated approach needed to halt the rise and harmful impact of diabetes in South Africa. Thank you.
Thank you. Thank you so much to Kathy Haldane. Very useful information, but I almost misinterpreted what she meant, because she says, you know, diabetes surveillance. I thought what they meant was they're going to get surveillance for every person who has diabetes. Like if you're in the sweets section, they are watching you, and then they send someone who's going to just, hey, put that chocolate down. TT, what are you doing with chocolate? But clearly surveillance, they're talking about something completely different. Don't forget, of course, to download the Diabetes Charter on www.diabetesalliance.org.za. And finally, we hear from Dr. Patrick Ngasa Pioti, who will be outlining the challenges and proposed solutions from the fifth and final work stream, which is research and innovation.
Hello, everybody. My name is Dr. Patrick Ngasa Pioti. Welcome, everyone, to the inaugural South African Diabetes Summit 2021. I will be presenting the outcomes from the research and innovation work stream. We discussed some challenges, and we offering proposed solution. We're proposing solution for the improvement of the diabetes response in South Africa when it comes to research and innovation. The first point we want to strongly highlight is the fact that there is no diabetes research is not a national priority in South Africa. For example, the questions such as how many people are living with diabetes in South Africa? What are their needs? Is the South African health system responding adequately to those needs? Are the resources distributed evenly? All those questions are left unanswered because of that lack of prioritization of diabetes research. And we know that research outputs usually inform policies. Therefore, we cannot have strong policies if we don't have a strong research agenda. There is no usually funds earmarked for diabetes research. It is true that some institutions, for example, academic institutions and private organizations are conducting research, but this is not a national effort. Last point on this slide is that currently projects that have been implemented and that have shown good success are not yet implemented at scale, usually because of lack of funds, but also sometimes because of the lack of support from the health authorities. A big problem or issue in the South African diabetes response is that self-management is suboptimal. Diabetes is a chronic disease, meaning the person living through diabetes should play a big role when it comes to self-care. Unfortunately, in the public sector, I'm sure you found the same pictures as well in the private, patients lack knowledge and are not empowered enough to conduct those tasks that they have to perform every day, which is called self-efficacy. We found that glycemic control and risk factor control, because diabetes is not only about the high level of sugar in the blood, it's also the LDL cholesterol and the blood pressure. Those risk factor control those risk factors are not optimally controlled. And a point here that we want to make is that because of the variety or diversity of the South African population, there are deeply embedded socio-cultural norms that are sometimes not understood or addressed adequately by the healthcare providers. As things stand at the moment, the approach to health in South Africa is outdated. It tends to be more a fragmented and siloed approach where healthcare it's seen from different programs. You have the TB program, the HIV program, the non-communicable diseases program. This approach need to stop. The other big factor and problem here is that the care offered to people living with diabetes is not person-centered, even though the word is used in the jargon, but in practicality is not materialized. Innovative solutions such as continuous glucose monitoring either lack scale or are unaffordable as things stand. But more importantly, because of that lack of a national agenda with research, it has not been proven or found whether those innovations would actually make sense in South Africa, whether they are cost effective and should be rolled out for the public. A person living with diabetes needs to be seen holistically. Therefore, there are some specialties that such persons should benefit from in order to have good care. By that, we mean, for example, food health practitioners, also known as podiatrists, and you also have your optometrist or ophthalmologist. We know there are not enough in the public health care system, and patients living with diabetes can go for their whole life without benefiting from those specialties. And it's a real problem, because those, for example, food complications and eye complications are the most reported for people living with diabetes. This gap needs to be addressed. Now we're going to take you through the proposed solutions. First and foremost, we believe that there should be a national agenda for research in South Africa, diabetes research more specifically, either led by the National Department of Health or the Department of Higher Education, or any other department that can fill that role. Funds, investments need to be put for diabetes research and innovation. That will also trickle down to academic institutions where there could be now career paths created for early researchers, young researchers who want to pursue a career in diabetes research, from, for example, having sponsored masters, scholarships for postdoc and PhDs. That will really prepare the next generation of researchers to drive the national agenda for diabetes research. Very important should be collaboration between the various academic institutions and centers available in the country. People living with diabetes must be empowered. It's critical, it's important, but how do we do it in the South African context with knowing our constraints and knowing our overburdened health system? That, again, is an answer that can come from our researchers. For example, how do we use innovative solutions like WhatsApp-based diabetes education to empower them and educate them? It's important. But how do we do it in the South African context with knowing our constraints and knowing our overburdened health system? That, again, is an answer that can come from our researchers. For example, how do we use innovative solutions like WhatsApp-based diabetes education to empower them and educate the people living with diabetes? The workforce, primary care, especially healthcare workforce, should be skilled in order for them to be comfortable using digital health solutions, as we know that is the future. Integrated team approach should be implemented in primary care. As we've seen in previous slides, diabetes or taking care of a person with diabetes is not only about glucose control. There is risk factor control, there are the feet, there are the eyes, there are the kidneys. Therefore, the team approach should be implemented and also used to monitor the care that the patients are receiving. It is important that we really build a supportive environment around the people living with diabetes. One of the ways of doing that is establish strong peer support models in the country. The researchers, the academics can assist in finding out what best models can work best in the South African environment. Would it be to have support groups? Would it be to have community-based groups? And what role can community health worker play in this whole endeavor? We know that the community health worker program is getting stronger. It's really supported by the Department of Health. They can definitely play a big role in diabetes care, as it has been shown in various research conducted in South Africa and elsewhere. Telehealth presents an opportunity to really fill many gaps that are existing when it comes to diabetes care in South Africa. Therefore, we really strongly push and motivate for the use of telehealth solutions. For example, for people with diabetes to have access to specialists, for primary care healthcare providers to have access to specialists for support and mentoring. And also, let's see a picture whereby the person living with diabetes through an app can be in permanent communication with a diabetes educator or clinician, and therefore be empowered and improve in his or her care. Funding and investments are necessary for us to develop all those solutions. We want to really put a strong call for the modernization of the healthcare system in South Africa. Obviously not for diabetes only, but for all other chronic conditions and acute conditions. Innovative interventions should be put in place. We should really strongly look toward digital health and investing in digital health solutions to allow our care and the way we deliver care in South Africa to be person-centered. The needs of people living with diabetes should be prioritized, and we need to find solutions to answer to those needs. Those include using digital platforms, putting together apps and other various models that can be tested and afterwards scaled up. It is important that we move away from a type of care delivery that's focusing on volumes. For example, in the primary care clinics where we are pushing the queues, to models focusing on outcomes, whereby, for example, it is important to look at what is the HbA1c of the people living with diabetes. Are they performing well? Are the foot exams being done? Are the eye tests being conducted? With all those solutions, we believe that the diabetes response in South Africa will be improved, and the people living with diabetes at the end will benefit and will be able to live better lives. Thank you.
Yes, indeed. Wow, thank you so much to Patrick for that. And right now, I think we have a few minutes. We have a few minutes to spare for the questions. So if you have any questions, I'm going to hand over to Susan, who's going to be taking those questions and directing them to the relevant people and getting those answers. Susan, are you ready to take the questions on?
Yes. Hi, Titi. Yes, I'm ready. Firstly, thank you so much for everyone for posting their questions. There's been some really nice questions, and I hope we can get to most of them.
I think your mic is still off.
Really?
No, I can hear it.
All right, let's do this. Before we get to the questions, let's play some videos. Let's play some videos from. We don't, as we said a little bit earlier on, that we want to, the whole point of the summit is to improve the lives of the people living with diabetes. So it's I think we better get to those videos of the people living with diabetes, get them to speak for themselves, so that we don't speak for them. We don't speak for anyone. Everyone speaks for themselves. So when we come back, we're going to be taking those questions from Susan.
Hello everybody, my name is Montembo Tloko. Welcome to Blue November. Today I just want to tell you about what changed with my diabetes care and what are my struggles. Since being diagnosed to now, things have really changed. The medication that I was on just after I got diagnosed with diabetes, this was 10 years ago, was just not doing much. And until I got my doctor who changed my medication. So I've made healthy eating and physical activity part of my daily routine. I walk in the morning, I also walk in the afternoon. And also with the help of my doctor, like I said, I'm taking a better medication right now. My daily struggle though, it's my fasting results in the morning. They're not so good. They're not too high, but they're not where I want them to be. So go out and get tested. It is World Diabetes Month.
Diabetes has come with so much complications over the years, and yes, my mental health was affected. Seek help through government, social workers, or your private psychologist, working with a good team to get a good balance in your diabetic life.
My name is Kirsten de Klerk, and I've been living with type 1 diabetes for 11 years. Around 4 months ago, I tested positive for COVID-19. It was an extremely scary time because I knew that diabetes was one of the highest comorbidities of COVID-19 in South Africa. My glucose levels were uncontrollable, but I was in a very fortunate position. I had access to my endocrinologist via WhatsApp. He checked on me twice daily. I also had access to continuous glucose monitoring via this flash glucose monitor known as a Freestyle Libre. I could share my results with my endocrinologist virtually whenever he needed to check in. It is my dream that every South African has access to this kind of care.
All right. Very interesting. And of course, we're going to be playing more of those videos just before we log out, hearing directly from people that are living with diabetes. Right now, though, I want to hand over to Susan, who's going to be talking and taking those questions that you've been posing. Susan, are you ready this time? Is technology not dribbling you?
I believe you were the only one who couldn't hear me. Can you hear me now?
Okay.
Is it good?
Coolies. But we're still struggling to hear you a little bit. I think maybe if
Susan,
we
we
can
can hear you.
a translator to translate what you were saying, perhaps that would be a but yeah, just try switching on your microphone so that we can be able to hear that lovely voice of yours properly.
You can hear Suzanne.
TT, I think
Might
they
take a
can
bit.
hear me.
Go ahead, Suzanne. Thank you.
So if you have any questions, I think this is the time to forward them. Susan is gonna answer those.
Okay.
Probably it's just
Suzanne,
yeah. But Susan, it's up to you then.
Okay, so I am going to go ahead unless someone tells me they can't hear me. So we've received quite a few really great questions. I think the first one I would like to position to Professor Levitt. There was a question which said, what is being done about the 50% of people living with diabetes that are undiagnosed in South Africa? So what is currently the interventions on that side?
Gosh, that is a very good question. And you've got me floored, basically. I think that I am not aware of any specific intervention. I think that by enhancing diabetes awareness in the community, one can do something. The other is to enable people in the community to understand what the risk factors are for diabetes. And so that if people fall into a high-risk category, that they would seek to be tested for diabetes. But there are no specific interventions that I'm aware of.
Thank you so much. Thank you so much for that. Then we had a very interesting question, and I'm actually not sure where to direct this one, but it is about tertiary linguistic departments. So how about involving those to develop communication on diabetes in terms of making it available in more languages? And there was someone else also mentioning this, that it's a big barrier in South Africa as well, that material and care is not available in more than English, I think, very often. Perhaps, Buyelwa, I'm thinking that you can perhaps share your thoughts on this with us. Not sure if Buyelwa is there. Anyone else on the panel that would like to comment on that question? No one?
Okay. Hold it, Buyelwa's here.
Yeah, sorry. Okay. Hi.
Oh, okay.
Okay, so you were talking about making the education material available in other languages.
Yes, Buyelwa. So there was a question around, what is currently happening in that space? Are there people developing material, or is there any attention given to that barrier in terms of care and education?
Care and education.
In different
languages.
Yes. In different languages. Okay. Yes, I think what we've tried to do, for instance, maybe I can make an example about the program that Prof. Bob Mesh was talking about, that has been rolled out actually in all provinces, the group education program. We have some resources that are used for the patients. And we have translated some of them to the local languages, like here in the Western Cape, English, Xhosa, and Afrikaans. And definitely those could be translated in the local languages, for instance, in Gauteng and KZN to isiZulu and Sotho and Tswana. I think here the other thing that I think is collaborations and people working together rather than reinventing these materials and stuff like that. And then when we work together, then we can just translate whatever is available. It's doable. On the other hand, sometimes patients prefer, English written, pamphlets, because sometimes it can be difficult to read some of the things in isiXhosa, for instance, because, I think that's what I can say. But I think here the important thing is working together and finding out what is already there. And I mean, even with that education program that we were talking about, there's a whole lot of programs that are already available that we just need to talk to each other and share whatever we have with everybody and see what can work.
Thank you so much, Buyelwa. Thank you.
Okay.
Then there was earlier on, someone asked about oral health care. So to say, we've been speaking about podiatry and eye screening, etc. But this individual says that the oral health status of diabetics is overlooked, yet periodontitis is considered a complication of diabetes. I believe that's a type of gum disease. Someone must help me there. And that it has obviously an impact on diabetic control. And the question here was, are there any plans to incorporate periodontal care into diabetic programs?
Perhaps Prof. Reda would like to answer, if he has any answers.
We all know that oral health is a problem. We all know that we don't have access to oral health.
I think Prof. Reed is struggling a little bit with
Yeah,
the...
sorry, Susanna. I don't know what's happening. Every now and then I can't unmute my my mic, so I have to just reconnect again. I take it you can hear me now?
Yes, perfect.
Yeah. So just quickly about the complication screening. Yes, so there are different ways of doing this. So we sort of advocate the 4B, 4C approach for good comprehensive care. So the 4Bs are blood glucose, blood pressure, blood cholesterol control, and then breathe air, not smoke. So every visit you should assess whether your patient is smoking, and you should assist your patient to stop smoking. When it comes to the complications, the 4 C's are check your eyes, so there should be an eye screening at least once a year. Check your mouth. You should visit the dentist at least once a year. So a dental visit is actually part of the guideline. In fact, many guidelines would propose at least twice a year, but at least once a year you should visit the dentist. As mentioned, oral health can be compromised by poor glucose control and vice versa. So the mouth exam is important, and then the kidney evaluation, and then the foot evaluation. But the mouth and the oral evaluation is definitely up there. It's definitely a priority. And we should also, that should be part of our, these are what we would call the 4 key indicators that should be assessed and should be monitored. So definitely the oral screening is as important.
Thank you so much, Professor Reeder. And I think it's over to Titi. Thank you very much, guys, for the questions and the answers.
All right. Thank you so much, Susan, and thank you so much to the panel and everybody for giving us those answers. Right now, we're almost right at the end of our program, but what a lot that we've learned today. We learned so much at the South Africa's inaugural Diabetes Summit. We'd love to get some feedback from you. Now, this is the portion that you get to answer the question that we have for you. What did you learn today? Simple question. We'd like to hear from you. What have you learned today? Please answer that question in the Mentimeter. Let us know what you have learned today. We'd love to hear from you. Straight after that, we're going to hear from the sponsors. Right. Thank you so much. Thank you so much to that. So the question was pretty simple. What have you learned today? What is it that you have learned today? We're going to take this moment and go back to the people living with diabetes, just to hear from them one last time, to hear from the people that are living with diabetes from what they have to say. Here's a video.
Hello guys, my name is Nompumelelo Kokola. I'm from Khayelitsha. I'm living with sugar diabetic. It's been 20 years now, but I'm living my healthy life. I'm trying my best. But my sugar was not controlled for a long time until my dietitian and my sister in my support group, in my great support group, asked me to try to stay away from starch and junk food. Ever since I took that decision, my sugar is controlled, and I'm so happy because I'm not going to see the doctor now and then. I'm just going to see the doctor for something else. And I know how to control my sugar. I know if it's high, what must I do?
Living with type 1 diabetes, it's always a greater challenge to function optimally. The burden of checking your glucose every day, of watching your diet, of managing your stress and anxiety levels, it just becomes overwhelming at times. And it's just so important that we we have a good support network in dealing with diabetes and mental health. Friends, family who truly understand, and other fellow type 1 diabetics who truly get it. I think it's important to include those in your circle to manage your diabetes and your mental health and to keep everything balanced.
What has changed with my diabetes care? I think after 12 years of being diabetic and finally joining a beautiful community of fellow type 1 diabetics, this community has really changed my diabetes care because it has opened my mind up to so many different experiences by so many different people within different circumstances, and taking into account and listening to people's experiences and their challenges, we're able to talk the same language. It has really blown my mind away. It has helped me a lot with my own journey, and I'm just so grateful to community. Everybody needs a community, and in that way it can help you with all the little things, all the big things, and just the journey on a whole.
All right, so those are the voices of the people that are living with diabetes, and we thank them so much for sharing that with us. Right now, of course, South Africa's first Diabetes Summit. We are very pleased to have with us an honorable guest, the Honorable Deputy Minister of Health, Dr. Sibongiseni Dlomo, is here to share with us and speak to and give us a message of support to everyone that's living with diabetes in South Africa. I'm going to hand over to the Honorable Deputy Minister of Health, Dr. Sibongiseni Dlomo. Thank you so much for joining us.
Seems your video is frozen, Minister.
I think we're having a bit of difficulty connecting to the Deputy Minister of Health, Dr. Sibongiseni Dlomo. So we're going to go back to him in a little bit. Right now, I think what we need to do is go straight to the sponsors and hear what the sponsors have to say. When we come back, we're going to try connecting to Dr. Sibongiseni Dlomo one more time. But right now, I think it's time for us to go check out what our sponsors have to say.
This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it?
All right. Thank you so much to all our sponsors that have made sure that they come on board and made sure that this day runs as smoothly as it has already. Right now, though, as promised a little bit earlier, we're going to be speaking, we're going to hand over rather to the Honorable Deputy Minister of Health, Dr. Sibongiseni Dlomo. Dr. Dlomo.
Good afternoon to our program director. I hope you can hear me. Can you? Hello?
Yes, doctor, we can hear you.
Yes, I'm sorry I had to switch on to another gadget because of the load shedding. I want to thank you all for the invitation to participate in this diabetes dialogue and convey my greetings to the members of the Diabetes Alliance and to all who have participated in this summit since this morning. I logged in early in this morning listening to all the very important contributions. All of you have convened this event to contribute towards a solution of challenges that we do face as a country. I may not have to go back to everything that was said, save to mention that as a department, we're looking at it as a non-communicable disease program, and we are fully aware that maybe we did pick it up that very early, that we have a quadruple burden of disease as a country. Non-communicable disease is just but one of them. And now diabetes comes within that very big family. The United Nations Sustainable Development Goals requires all countries, including us, to reduce premature mortality from non-communicable disease by 1/3 through prevention of treatment and promote mental health and well-being by 2030. I agree with most of the speakers here that most low and middle-income countries, we are not on track to meet the target 3.4 and related targets of the Sustainable Development Goals of this Agenda 2030. We have a responsibility to accept and accelerate our responses to NCD within the context of growing multi-morbidities. These multi-morbidities are growing and are at a worrying levels. Colleagues here have mentioned the issues of overweight, obesity, and all those that are actually impacting. Our presence here in this meeting, among other things, is to demonstrate our acknowledgement of the role that all of us collectively can contribute towards the government's response on the prevention and control of NCDs. I would like to assure you that as one of our partners, we share a common concern about the escalating burden of non-communicable diseases, including diabetes, and together with you and related stakeholders, we can strengthen our combined response. I won't go to the statistics that have been quoted by our colleagues, but just to save to mention that we're saying there are 4 million people estimated in our country with diabetes, 2.4 million of those who are undiagnosed. Now, there's a question here that was asked. Let me pause there a bit to say, what do we do with the 2.4 million of undiagnosed? I'm inundated with a lot of calls from doctors who are doing, especially those who trained in Cuba, who are doing community service. They say, who are finishing internship, that Dr. Dlomo, I would like to go and do community service in a clinic, far-flung in the rural area. And I asked them why. He said, I would like to, when I see a diabetes, a hypertensive person coming into my clinic, to open a family file and go out in that family, walk there, and not wait for another member of that family to come to my clinic. Walk into that community and say, how many more other diabetics are out there, unaware, undiagnosed? So it is really to change the mindset to say, if we do wait for persons that they themselves suspect that they are diabetics in our clinics, we'll never get to deal with these 2.4 million who will remain undiagnosed. The statistics in the country are informing us that the mortality out of diabetes is far, far more higher amongst women and is the second leading cause of death in the country. It is worrying, therefore, that the data reported by Stats was given to us long before the COVID-19, which means with COVID-19, we may be looking at a much worse picture. Because again, we are informed that the combination of diabetes and COVID-19 infections are much more likely to develop into more severe and critical disease, requiring patients to be admitted into ICU. The research is showing that not only having diabetes, but glycemic control achieved by patients are determining severity and mortality resulting from the COVID-19 infections. It also illustrated that those patients who had well-controlled blood sugars before and during COVID-19 infections were less likely to die than those patients who had poorer glycemic control. The recent research also demonstrated that persons infected with COVID-19 who were treated with steroids are at risk of becoming diabetic post-COVID. Now, as a simplistic level, the risk of the existence of a pre-diabetes could be prevented by addressing our lifestyle. I'm not going to go into that. Colleagues that have spoken here this morning, we are actually talking the same language. As I prepared this speech, it was like we are all together in it. The department is aware that improving the prevention and control of the non-communicable disease, including diabetes, at the community and district levels of care cannot be overemphasized. We are in the process of approving the National Strategic Plan for the Prevention and Control of NCDs, which is based on a multi-sectorial integrated person-centered health service approach. I'm pleased to announce that this NCP introduced the concept of care cascades, similar to that we did for HIV and AIDS, where it strives towards strengthening the NCD surveillance, strengthening self-management, and promotes the development of essential service benefits packages in line with the universal health coverage through NHI. Additionally, let me then inform this meeting today that shortly the initiative by the minister is going to kick in very soon, where he will be launching a program that is aimed to strengthening the community level of continuum of NCD care through the use of community healthcare workers. This, while it will be introduced in KwaZulu-Natal, the project will expand throughout the whole country. We will then actually inform the minister and share what we have just heard today, so that you too can be invited early to be part of that, where the minister will be going all out to have an early identification of diabetes and hypertension and encourage linkages to care. It will also enable and support enhanced self-management, adherence, and empowerment of persons with NCD and their families. I cannot ignore that our people also have an escalating burden of these comorbidities. While we address the holistic needs of our patients, we must improve our capacity and competency to better manage patients with diabetes. South Africa was pleased to be a co-sponsor and contribute towards the World Health Assembly resolution on diabetes in May this year. This resolution requires us to ensure equitable access to equality and appropriate diabetes care, which, if done in South Africa, must be located within the context of a broader NCD prevention and control. We agree with you holistically. The task before us is huge, but I firmly believe that you and many of our stakeholders will support our endeavors to promote wellness and also enhance the quality of lives of persons with NCD on our country. We owe it to our South Africans. Early diagnosis, early identification will be a way to go in terms of increasing the life of our citizens. I thank you very much.
Well, thank you so much. Thank you so much to the Honorable Deputy Minister of Health for joining us and giving us that address. Well, to end off South Africa's first Diabetes Summit, we'd like to invite Bridget McNulty, the chairperson of the Diabetes Alliance, Living with Diabetes Type 1, to come and outline what the Diabetes Summit means for people living with diabetes. Bridget?
Thank you so much. I am here just filled with gratitude and thanks today. Huge thanks to Dr. Kiloma, the Honorable Deputy Minister of Health, for joining us today. Thank you to all our speakers. We have had an incredible lineup of speakers today, and everyone for giving up their time and giving their attention. and really tackling this concept of, we know there's a diabetes crisis and how can we improve it. So I am so grateful to the speakers, so grateful to the Deputy Minister. I'm also so grateful to the members of the Diabetes Alliance. As Titi said, I'm the chairperson of the Diabetes Alliance, but I in no way pulled this amazing event and the charter together solo. We have had the most extraordinary teamwork. To all the volunteers who participated in the work streams, we literally couldn't have done it without you, and to the amazing planning committee who helped work with us. It has been a very ambitious goal, and I am so delighted that so many of you have joined us here today, and I'm so grateful to everyone who came here today. We've had an array of people from all over the country and from academia and from public clinics working in healthcare and medical aids and funders and parliament. It's really just been the most extraordinary meeting of minds this morning. And I want to echo what Dr. Dlomo was saying earlier, that we're all speaking the same language. And I think that's the most important thing when it comes to diabetes in South Africa. Our hearts are all aligned in that we want to help the people living with diabetes. That is at the core of everything that we're trying to do here. And I think that's what makes this so beautiful, right? That we have all joined together to try and make life better for people with diabetes in South Africa. And I really want to encourage you to go and download the Diabetes Charter. We have made it as user-friendly and accessible and easy to read as possible. It's 30 pages, but that includes many pages of references. And it really, we're looking at it almost as a menu of, here are the various challenges that we're facing with diabetes across the 5 themes that our work streams outlined earlier. And here are some proposed solutions, and they're evidence-based as far as possible. And it's really just offering a way for anyone, whether you are an individual or a company or an organization or an academic institution or from government. It's offering an opportunity to be able to choose where your passions lie with diabetes and make a tangible difference that is in alignment with what we are all trying to do. This is our inaugural Diabetes Summit, and we somehow pulled it off. And we'll be holding the Diabetes Alliance, we'll be holding one every second year, and we'll revise the Diabetes Charter every second year. So I also want to stress that this is the first document that we have ever created as the Diabetes Alliance for diabetes in South Africa, and we want it to be an alive working document. We've included contact details in the charter for if anyone has suggestions. This is something that's collaborative and co-created, and we want it to be a living document. It'll be officially revised every 2 years, but we really want people to get stuck in and engaged. And so in closing, what does this mean for people with diabetes in South Africa? I've been talking a lot in the media this week, particularly ahead of World Diabetes Day on Sunday, and I keep rolling out the same terrifying stats that we all know. Diabetes is the #1 killer of women in South Africa, despite it not being a lethal condition. It's the 2nd leading cause of death in men. This shouldn't be happening. There's no way this should be happening. Also, 1 in 2 people with diabetes are undiagnosed, as we've mentioned. And according to the SA Demographic and Health Survey, 2 in 3 people with diabetes are in the pre-diabetes range. So they're on track to develop type 2 diabetes if they don't change their behaviors. So these are either the most depressing statistics ever, or offer us a really hopeful future picture of diabetes in South Africa. Because if we know at the moment that diabetes is killing more women than anything else, but it's a preventable condition if diagnosed earlier, and a very manageable condition if diagnosed later, that means that we can flatten the curve of diabetes. And I really want to borrow from this language of COVID because I think we all understand it. We are on the rise, and if we can use some of the solutions that we've created together and work together and collaborate as much as possible with all the stakeholders in this field, we can really make a difference to those people, those 2 in 3 people who will develop type 2 diabetes if nothing is done. We can prevent them from developing type 2 diabetes or diagnose them early enough so that their type 2 diabetes is manageable. And I think that is an extraordinary opportunity. So I'm hoping that what this Diabetes Summit and this Diabetes Charter does is it changes the course of diabetes in South Africa. At the moment, we're in a crisis. We're heading for a diabetes tsunami. All the words used around diabetes are car crash mentality. And we can change that. The people in this room, this virtual room today, the people who will be reading the charter after this, we can alter the course of diabetes in South Africa. And I'm so grateful to all of you for being here today in the hopes that we start charting a different course for diabetes. Thank you. Wait, one last reminder, Diabetes Chart is available on diabetesalliance.org.za for download. Thank you.
Oh, thank you so much, Bridget. Thank you so much. And that's about it, man. That's it. From myself, TT Pasha, the Diabetes Alliance, and the South African Inaugural Diabetes Summit, we'd like to thank you. We'd like to thank all the speakers that have come through and shared with us, the honored guests, and of course to you for spending the morning with us and sharing everything that we have shared together. Of course, together we can make a difference. From me, Mr. TT Pasha, I am Audi. Until the next time, thank you so much.
Bye-bye.
Thank you, everyone.